phosphotalk?
The data on tau, let me get to that. The data on tau was negative so far.
It was
But
negative.
yeah, it was negative. Remember that these were exploratory endpoints. The sample sizes are way smaller than you've seen in other studies. So this is, these are like 100 or something like that, 150 per arm or something like that. But they have shown no effect on tau so far.
Okay, thanks.
Yeah. Other questions? All right. Yes, Dr. Hanan.
Thank you for this fantastic lecture, and this is really promising. Is there any interaction with acetylcholinesterase inhibitor? Since now we're working on multimodal targeting multiple mechanism in addition to anti-GLP-1, would that be imaginable as we will target a
Right. So far, there's no problem with having acetylcholinesterase inhibitors on board. Most patients are on them. I'm not sure if there was a restriction on memantine, but acetylcholinesterase inhibitors, there's been no problem.
Thank you.
Mhm.
Any question?
Okay. Yeah. Great. So we'll start the next session.
Our next guest is I'm very honored to introduce an icon in quality improvement in the whole UAE, and he's also the quality guru at our Cleveland Clinic Abu Dhabi. Dr. Samer Ilham is currently a Cleveland Clinic caregiver, Cleveland Clinic US. Second as a senior cardiovascular consultant, medical director of continuous medical improvement, and director of accreditation, quality, and safety Institute at Cleveland Clinic Abu Dhabi. Dr. Raham is American board certified physician, board certified internal medicine, cardiovascular disease, vascular medicine, and American board of quality. He was recently recertified in 2017 by American Cardiology and ABIM. He is certified in professional quality improvement CPH. Q by National Association. I'm so honored I can go for maybe a year on Dr. Laham, and you can Google him, and please have.
Thank you very much.
Thank you.
Thank you very much. Thank you, Dr. Hanan. So thank you, Dr. Marwan, for a fantastic conference. Thank you, Dr. Hanan, for the nice introduction. Thank you, MCO, for all what you did. Thank you, KU. I've been collaborating with this institution for around 5 years. I do my own introduction again for the upcoming speakers. Sometimes we spell the name, sometimes we say something not right, and we respect all cultures, especially in UAE. So please take 30 seconds or a minute to introduce yourself too. So I'm a cardiologist in practice. I'm a professor in Cleveland. I've been with Cleveland Clinic, Ohio since 2010. I'm also a very passionate person about quality, and around 5 years ago, I got sick of this reactive healthcare. I got sick of this advanced but not reliable healthcare, and I got sick of the mediocrity of healthcare. Wow, that was good. Because there is no healthcare. The word healthcare does not even exist. If anyone has ever seen healthcare, please wake me up in the morning. There is sick care. So the only hospital that I truly believe in its name is the Hospital for Sick Children on Great Ormond Street in UK. So I'm gonna be flying with you a little bit to talk about AI. My mom is 90 years old. Dr. Hanan knows how much I love her. You all love your mom, but not as much as myself. And the memory is going a little bit down. So I got to collaborate with this fantastic colleague. And my role today is to do the forest and the tree. And then Dr. Shehi will start doing the leaf. And the other speaker hopefully will go into the chlorophyll and maybe the DNA. So my role is to focus on AI. Around 5 years ago, I decided to look at what is this AI, what is this blockchain, NFTs, LLM, metaverse, and we collaborate here. For people coming from outside UAE, we have more than 40 plus publications. I'm a reviewer in New England AI, Nature. So there's a lot of good work being done in this part of the world. UAE is really the diamond of collaboration and also the diamond of growth. So with this intro, this is my hometown, which is Cleveland Clinic, Abu Dhabi, and I'm a cardiologist talking about memory, brain health, Alzheimer. So I have no conflict of interest at all, zero. This is what I'm going to say, public speaking. Tell them what you're going to say it, then summarize what you said. Keep them awake. There'll be lots of photo. The number of slides do not reflect the time that I will use. So you'll be surprised. What is this kind of slide? Yes, patients want safety. So this is what Dr. Marwan was talking about. Safety in the intervention. They want heal me. They want results. He showed us this a few minutes ago. They want kindness and patient experience. A once-a-day drug, twice-a-day drug, side effects. He mentioned nausea, etc. 25%. But the most important thing that they want, and that is the secret bullet, is engagement. I discovered a long time ago medications don't work till you take them. Did you ever discover this? And we don't even think about compliance. I will not just spend too much time on this. I will let you know that I strongly feel that the intervention of digital health, if there is anything that it does, hopefully it's improved engagement. We are looking for zero harm, and this system doesn't work very well. It's my paper on the domino effect of medical error, and communication is very poor. So why would I say this in a topic like this? Because I need to show you this. So the current trend in medicine now, and this is very important, is to look at preventive medicine. I don't care about the rest. You can look at the slide. Medicine is not preventive. It is reactive. And it's too late when we intervene with memory, heart, and the rest. And that is my role. So I thought I was smart. No offense to our president, but I'm going to go to China if you don't mind. And we're going to go 2600 BC. And we're going to look at ourselves. How many physicians in the room? We're going to look at ourselves in the mirror. Have the slide, and I'm going to read. I'll start below. Inferior doctors treat the full-blown disease. No comment. Mediocre doctors treat the disease before it's evident. Before. And superior doctors prevent the disease. This is not AI. This is a long time ago. So this is what I'm trying to do. So I show this slide in every single cardiology lecture that I've ever given here in the States or anywhere abroad. Heart attacks, dementia, Alzheimer should be prevented 50 years before they happen. I totally disagree. Are you ready? Yes. That's where you start working. So when Dr. Shehi will talk about genetics, do not take it lightly what is being done in UAE at all. Not only for UAE, but globally. But the trouble is, this is, I'm sure you know this actor, for whatever reason, working with Disney, decided to do some blood testing and some other testing. And guess what? His gene have 2 copies of one of the genes that maybe Dr. Shahi will teach me about. So he ended up taking 3 months to try to have a healthier lifestyle. So knowing a lot needs to be part of an algorithm that adds value, because sometimes knowledge is useless. Okay? Artificial intelligence. This is where we used to be. This is where we could be. This is where I guess we are. So around 1950, a group of interesting people met in the northeastern part of the United States, decided to coin the term artificial intelligence, which I totally don't believe in. I think it's augmented intelligence, not artificial intelligence. And then they forgot to remind us that it all started in this part of the world with the word algorithm. So algorithm is Al-Khwarizmi. And we have Al-Khwarizmi Center actually around 20 minutes away from here. This is not my opinion. This is the opinion of BBC. So let's do a quick cooking class. Anyone interested in cooking? No one? I like this guy. A man cooking. Who said that only women should cook? So I'm going to do a recipe for you. So with food, you have a recipe, raw material, dish. Am I doing well, Dr. Hanan? Is this good cooking? So for the AI part, I call it algorithm, data, and result. That's really as simple as it is. So artificial intelligence, 100 definitions. Briefly, a machine, a computer doing what we typically do. Machine learning, it learns without being explicitly programmed, but deep learning for neurologists, you please look at deep learning because it's really neural network. It's almost like the neuron of the brain. If any specialty should be dedicated to be interested in deep learning, then definitely it's neurology. So this is digital health. And this is what we call healthcare 4.0. This institution with Dr. Khalid Salah is a leader globally of blockchain research globally. And blockchain is even much more interesting than AI when it comes to dementia. So now we know that we have big data. I transformed myself. I'm not better. I'm slightly better. I'm not smart. I'm a student. But you may like to consider doing the same in your specialty. So this is from my colleague, a tool in Stanford. Hiding within those amounts of data is knowledge that can change the life of the patient, but also of the world. This data that we get from electronic medical record is not, we're not seeing it. We're not even smelling it. We don't even know it. And please look at your own data and you can do better. This is not at all to show off. This is to encourage, especially I was told by Dr. Hanan, I can see there are students sometimes showing up to encourage people to get into this. This article took me 9 months to write, and the second author is my daughter. The last one is from here. My daughter was 16. We sat down to write this article together, and I started with quality in AI, is what I'm at. And then we went into this and that, but to show you that this place and others, we are very, very involved in doing good research that is related to healthcare. This paper from our colleague here, and I'm a senior author, got the award in IEEE in the United States. Okay, good job. Move on. Okay, now where do we fit with this? What do I know about this disease? I'm not a neurologist. I'm not an expert, but I'm a loving person. So thank you for allowing me to be here. So we heard in the past 2 days about this very important challenge. We know about it, and you will teach me about it, so I'm not here to discuss it. You've seen this slide, and you may say it's 55 million or 58 million. You know we were underestimating this. You can say it's the fifth leading of death or the seventh leading cause of death, but we know it's very, very serious. And we know it's also extremely expensive. And you are not here to listen to me telling you about mechanism of action. You definitely don't want to hear this from me, but just kind of reminding myself. But then when I look at this and I look at these layers, and I'm sure there are more than normal MCI and dementia, I'm sure there is more than that, maybe 100 stages. It's important to see if AI can move us a little bit faster or slower or better in the direction. Please remember, I'm going to be doing the forest and the tree, and definitely I have no time to go over the leaves. So current gaps in Alzheimer from my reading and what I'm seeing with Dr. Hanan and my own mother, who's okay, but kind of memory is going down, typically occurs late diagnosis. What's new? This is not only AD. This is everything. High clinical trial failure rate. What's new? Not only with this, but maybe more. Lack of individualized therapeutic approaches. Dr. Hanan is my witness on our discussion regarding mom, and then fragmented and inaccessible data. That's not only with AD, that's global. Everyone, I want my data. Okay? This will be transformed and read my lips and look at my face when blockchain will take over. From internet to cloud, which and anybody, all your cloud is being looked at now by someone else and myself. But the blockchain will truly be the smartest way of communicating and transferring data. And we have two papers on how to do studies and real trial research with blockchain. So from the misdiagnosis to the underdiagnosis to the dead diagnosis sounds so familiar with medicine, but especially with AD. So what's the urgency? Despite all these decades, and thank you, Dr. Marwan and the team, and who am I to even comment on these studies, for making every effort to move along, but therapy is definitely not going as fast as it should be. New drugs like the anti-amyloid therapy show promise but are not curative, as far as I know, and there is a critical need for earlier intervention. And if there is anything that needs personalized care, then definitely it's AD. So I love these photos and they are amazing and you can make these photos and this is amazing. But all what I know is that when you have a family member with this, or when you are a physician, or we are a caregiver, or a person, or a Homo sapiens, you feel that this is moving very, very, very slowly. And like all other entities in healthcare, it is reactive for the most part. This is from Washington Post for people not from the States, a reasonably acceptable newspaper, and talks about AI could monitor brain health and find dementia sooner. Wow, okay? Typically, when I do these kind of conferences, if it was cardiology, I choose only two articles, dig, and it's almost like a journal club. Since this is not my specialty, and I'm talking about AI as the first speaker, and to set the tone for Dr. Shehi and the other speaker, I'm going to be again doing the forest. So why artificial intelligence? If you look carefully at this, and I'm sure you did, but please make it a hobby and a commitment. Please, wherever you are, have a person dedicated in your own group, young or old, experienced or not, to really make this their thing, their niche, wherever you want to call it. To accelerate discovery, diagnosis, and treatment, there are data that we can barely keep up with, and very importantly, the advance in the power of computation. So this is definitely something worth looking at. And the biomarkers, obviously, in all what we hear, are great and they can take us in the right direction, but this, whew, needs to be adjusted in a completely different way. So this is, for example, one example where AI models integration of PET imaging, CSF tau levels, and voice data to predict progression of risk. So in this institution, there's a gentleman called Emre with quality. Maybe all of you know it from here. We do risk assessment and risk management for medicine and for quality. Nothing is worse in healthcare than our risk prediction. I spoke once at the Intercontinental Hotel in 2010 with the president of the American Society of Quality, and we said, we are never, ever more delayed and backward in healthcare than we are with risk assessment. And I'm not trying to be a pessimist, I'm trying to be a realist. So this may be one way how we can really do this and hopefully create a global ecosystem where we could look at this, interacting the data and working together. And very importantly, optimizing clinical trials. And again, this is not only for the very important AD, but also for the other specialties. And I think this goes without saying. But to give you a flavor of this, kind of, he's talking too general. I like the people who show us the p-value and the logarithmic trial, etc. I will take the example of the digital twin. How many of you know about digital twins and use them in research or in clinical practice? I'm not going to ask if you have one publication on this. Okay. So just kind of for my colleagues who may or may not, this is invented by me. So a digital twin is a virtual replica on individual brain, in this case, and health status, built using real-time data to simulate the progression and treatment of AD. Imagine. So we call it a digital twin. It has tons of features. I don't have time to go over this. It's too technical. The application is my favorite. Early detection. Early detection. I don't know what to do about this. Shape the universe. Early and then simulation of therapy, optimizing care, and enhancing clinical research, and has tons of applications. And there are data on this. If the lecture was a grand round, 45, 50 minutes, I'll show you tons of examples, at least early on, some from Mayo. So with this in mind, we can really do something very special with artificial intelligence. This is an example, and I did it like a very, very basic, please forgive me, this is not how I typically present, but this is from one of the journals that I am a reviewer of, looking at the model and prediction of clinical symptoms in AD using data. And again, it brings up in the paper that AD has a progression, it can be stable or decline. I Googled Dr. Marwan before coming. It turns out this is one of your interests, right? The decline of the, how people can really get bad quickly or not. Very heterogeneous, again, from some paper from Dr. Marwan. Clinical assessment or the MRI, and then they added one additional visit and said it's not enough to do the amazing work that Dr. Hanan does in our hospital and takes time, by the way, and cognitive tests, but also to add another component to it with machine learning and one aspect of deep learning. Time does not permit me to go in detail, but just to give you an idea, comparing stable and the one who declined and looking at the people who progress with now 3 visits. Very briefly, again, you like to see data, but we don't have time. 90% accuracy in a better prediction. Not perfect, it's only one paper in a good journal, but something worth looking at. This is another thing which I'm sure you're expert on from Emory. And again, when they did the digital one, less time. It used to take 45 minutes to 1 hour. Now it's around 10 minutes. Much better prediction because it's digitized. It can go into a huge database. Emory, which is in the southern part of the United States in Atlanta, is using it in all their primary care clinic. I always say, you don't prevent heart disease by going to cardiologists. Same with neurologists. Primary, primary, primary. And then don't get me on the retina. Don't get me unlimited interest in retina. I want to do retina instead of cardiology in prediction. Again, very nice articles on this. I'm only showing you this kind of with correlation with PET imaging, etc. And then very interestingly, a group from New York looked at having a device that you take at home for 15 minutes, or you can do it at the hospital and can be a very good predictor. So again, this is IBM and Pfizer also showing one of these interesting tests. Who likes statistics? Raise your hand. Anyone? Nobody. Okay. Is AUC 0.74 good or bad? So as you know, this is from their publication. AUC below 0.8, at least in cardiology, I don't take very serious, right? You need it to be more than 8, but 0.8. But anyway, something interesting worth looking at. And I know I'm going fast, but just don't want to go over this. This is another paper looking at AI and integrating MRI. This is interesting, the brain cell versus universe. I'm sure you've heard about it. And going all the way, I'll show you just the last slide because there is no time. At least in that study, 98%, go back, Mr. Okay, up to 98% one-stop shop diagnosis with high accuracy. Again, it looks too good to be true, wow. And this is pathology, your amyloid stuff. Again, done in one of the pathology labs in California with much, much better prediction. But before I go to the summary and the conclusion, this is my favorite. There is in Europe this site. Are you aware of virtual brain in UK? Anyone? Just curious if this is real or not. Yes. So apparently this is very interesting for simulating, doing research, doing modeling, doing AI stuff. So cardiologists, what do I know about this, right? Tomato or eggs, right tomato, left eggs. But this apparently is a very promising way of doing this and doing really predictive research in brain health. Please look at it. Dr. Hanan, maybe we can take it offline, you and I'll move fast. Okay. Case studies, I'm just going to show you one word and then move on. Wearable, boom. Real world examples in piloting, generative AI for hypothesis generation, NLP, which is natural language processing, looking at data to improve outcome prediction. We can talk more about this, federating the learning globally. And then very interestingly, I'm kind of going to be writing my first paper on anything with memory and AI, specifically on data on retina. So very briefly to end, the summary of what I'm trying to say is risk prediction is key in healthcare, and we do a very, very poor job in it. And in AD, this is even more important because it's affecting everything, even mortality, quality of life, family, etc. Diagnosis. We can do a lot better in everything, especially in AD. Monitoring. I had to go fast. I need a grand round, not 20-minute drug, and care management. So in conclusion, AI enables earlier, more personalized and scalable AD care. It augments, not replaces the role of clinician, and that's very important. It needs a multidisciplinary interest. Till now, there's a huge resistance, even in my institution when I do AI research, and I'll be very open. AI can transform the landscape of AD. Few more comments to make this more fun, the future. So I think we're going to model this in a more and more ethical way. But are you aware of this robot? Anyone? So you think of robots, something big doing surgery remotely. These are what we call micro robots. Those will be going to the brain, going to your body. And this is, I did this, Dr. Shehi, where is she? She was in MIT. So this is something I will be doing directly or indirectly with my colleague in MIT. Also can deliver the drug. As you can see here, it's a very small one. But this is my ultimate favor. ECG predicting hyperthyroidism, ECG. ECG predicting kidney disease. ECG predicting diabetes. So why not predict AD when I do the model type? Not convinced. Chest X-ray. This from many, these are the references. Nature. You look at the chest X-ray, you may be able to diagnose or at least predict the likelihood of diabetes long term. But you don't believe it. The retina. Brain, retina. AD, memory. That seems to make a lot of sense. So diabetes, pressure, kidney, diabetes I understand, kidney I understand, liver maybe, Alzheimer, wow, now we're talking, okay? Our topic, predicting heart attack, hyperlipidemia, and your famous Parkinson's when my colleague was talking about degeneration. You see what I'm trying to do? Let's stop being so subspecialized, but also talk to your other next door colleagues. We may do a better job by working as a team with different specialties. This is one of the Nature paper. Precision medicine is where we are. This is the model. And very importantly, please let's not look for our fax machine. Let's really be progressive. And we have a lot of work to do. One step more with AI. These are my references, and I thank you very much. And again, forgive me if I did a lot of forest. Okay. So, yes, sure. So the next speaker is Dr. Fatma Al-Shahi. I would kindly ask you to take 30 seconds to 1 minute of your time. When I'm in the States, different countries, everyone says the name wrong, etc. So I can speak because I speak Arabic. Dr. Amna Muhammad Al-Shahi. Incidentally, a very large family in the UAE. She's an assistant professor in Khalifa University. The topic that she's chosen is AI in Alzheimer's disease research, from data to diagnosis using medical records, my favorite topic, underused, oppressed, imaging, which is what I was talking about. Now we're going to go to the leaves. And then genetic data, and she will tell you about the amazing genetic research in this country. She's an assistant professor in KU. Briefly, she was both in MIT and in Imperial College. And very importantly, her interest of research is more and more exactly on the topic that she will be discussing. Please join me in applauding, welcoming our colleague, Dr. Shahin.
Thank you so much. Okay. Hi everyone. Good morning. Assalamu alaikum wa rahmatullahi wa barakatuh. Okay. So first of all, thank you, Dr. Ham, for setting the stage for artificial intelligence for my talk today. And thanks, Dr. Abdul Adam, for inviting me to this talk. So today I'm going to talk about artificial intelligence research, and specifically for Alzheimer's disease. So in today's talk, I will talk first and brief, introduce you guys about artificial intelligence and Alzheimer's disease, and why we consider Alzheimer's disease as a biomedical challenge for our time. Finally, I will talk about some research and the role of AI in healthcare, and all the talk or the research that I'm going to present is based off my research team here at Khalifa University. So let's talk first about what we mean by artificial intelligence. Artificial intelligence is actually the science and engineering of creating an intelligent machine. And the main objective of those tools is actually mimic or try to make the machine understand or do behavior or smart behavior that we as a human do it easily. Within machine learning or within artificial intelligence, we have another subdomain which is artificial or machine learning, which is actually a domain that focuses to learn the rule by mapping the input to the output. And when we look at machine learning, we have high-level pipeline in which I have my input data, whatever it is, like electronic health record or genome data. Then we have a stage called feature extraction. Then the classification, which is a type of machine learning model in which we have many. And finally, we have an output, which is the task that we are interested in. So to clarify a little bit about feature extraction, which is actually an important stage for any machine learning to success. So even though for machine learning we have a lot of algorithm and a lot of model, but this stage is really a core component or core stage to define the success of any machine learning model. So in a brief, what I mean by feature extraction. So suppose we have this image with a specific tumor on it. Feature extraction is just calculate some information from the tumor, like first order statistics such as the mean, variance, because at the end when the computer reads an image, it reads pixel, it reads numbers. So we can take the mean, variance, or we can look at the shape of the tumor and those stuff. And it's really important to know that all those machine learning models that underlie machine learning in general take table representation as input. It's not like it take an image as image. That's why we need to first extract some information, put it as a table representation, or for each page it will be one row, and then we will feed it to machine learning model. Okay, and those are the machine learning algorithms. So we have decision tree, gradient boosting model, random forest, support vector machine, logistic regression, naive Bayes. So in terms of machine learning, we have many models. But again, the success of those models depend on the previous stage, feature extraction stage. Within machine learning, we have another domain, which is neural network. And as Dr. Ha mentioned, neural network is actually inspired. Its functionality or those algorithms inspire their structure from the brain neuron. So in this kind of architecture, we have an input layer, an output layer, and different in-between layers. Okay? And again, inspired from the brain cells or brain neuron, how it works. And within our neural network, we have what we call deep learning. Okay, so deep learning, which is like most of latest advances in AI or machine learning or whatever, is actually referred to the deep learning, which is actually subset of what we call a neural network. And if we look again, because deep learning is just a subset of machine learning, and we have actually specific stages like input, output, similar to any model. But if you notice in between, now we have feature extraction and the classification become one stage. So now, instead for us, previously, like we do feature extraction as separate stage and then feed it to the model, and this stage is really important. Now let's make the model understand those features. And when we look at some common of deep learning model, we have multi-layer perceptron, similar to neural network. This type of architecture take table representation as input, like genome information or electronic health record. But what if I have image? So for traditional machine learning, I need to extract some information from the image before we feed it to machine learning. But with deep learning, now no. We have a specialized layer that take an image as an input and process it. And then we have another type of deep learning model, which is recurrent-based neural network that deal if your data is a sequence, like EEG, ECG. So there are specific characteristics of those models, so that's why we can train recurrent neural network. Yes, algorithm. So now after I brief you about what we mean by artificial intelligence, let's talk about Alzheimer. So we know dementia is an umbrella term that contains many degenerative diseases or disorder, and Alzheimer's disease is the common type of dementia. All those diseases have some common characteristics that they are chronic, persistent with no cure. They cause by damage in the brain cell, and the type of dementia depends on the region of the brain that affected. But it's really important. Unfortunately, currently, a lot of people think Alzheimer's disease is part of aging process, which is not correct. Alzheimer's disease is a disease. And unfortunately, there is a lot of misunderstanding to this fact. So why is Alzheimer's disease considered a biomedical challenge of our time? There are many issues and many challenges that people face in terms of the applying AI or machine learning on Alzheimer's disease. One of them is a lot of people live with Alzheimer's disease and they are underdiagnosed. So undiagnosed, those patients, for sure, it will delay their treatment plan and toward early diagnosis. No cure for Alzheimer's. So until now, there's no approved cure for Alzheimer's disease, and all the diseases or the treatment that toward Alzheimer's actually to reduce the symptom of the disease. And finally, there is a high failing rate in terms of drug development. So 99.6 of clinical trial fail to find a disease or to find a treatment for Alzheimer's disease. So now I want to talk about where AI and Alzheimer's disease or healthcare came together. So we know in healthcare we have a lot of diverse modality and data. It's a domain that's rich with different data about patients. Like we have electronic health record, clinical note, laboratory test, image, MRI, CT scan, EEG, ECG. All those data actually have rich of information, and each one can represent a different dimension of the disease. And this is actually explain why nowadays with AI, for example, we have different type of model. Some model that take table representation as input, some image, the others take like a signal. So if I'm going to talk about some of the theme where AI can play a huge role here in Alzheimer's disease, and specific for this talk, or in general for healthcare, we can find it, for example, in drug purpose, risk factor identification, early disease diagnosis, and patient stratification. So now I'm going to talk about some of the research that had been done by my research team at Khalifa University, and some of those research had been done back when I was a postdoc at MIT. So in terms first of drug repurpose. So as I mentioned in the beginning, I am AI expert. So it's not like I do any kind of wet lab or mice experiment or those stuff. All my work based on working with existing data. So in terms of drug repurpose or drug reposition, it's actually a domain where I can reuse existing drug that are approved for a specific disease to treat another disease. And the importance of having drug repurpose are, for example, for the domain like Alzheimer's disease, in which we don't have a treatment. Can we repurpose existing drug to treat Alzheimer's disease? And especially for the domain similar to Alzheimer's disease, where the clinical trials have a high failing rate. So that's why drug repurpose can provide an opportunity to find a treatment to delay the progression of disease. I'm not talking about prevent it, but delay it. Okay, and this is what the research objective of current work, which is, can we do in silico a clinical trial in which, based on clinical data that already stored and exist, can we use this information to create some kind of in silico clinical trial to find the efficiency of those different drugs? For those kind of study, for sure, we use again medical record or existing patient data. We find cohort selection, what we are interested in, extract some co-founder or feature from different patients. Then we have what we call propensity score analysis, in which we try to reduce the bias. Again, this kind of study, it's not like we have a true clinical trial and the selection of cohort based on some criteria. It's like the data exists, right? We need to reuse it, but we need to consider how we can reduce the bias that had been imposed on the data. So that's why we use what we call propensity score to help to reduce bias, and then we can apply different algorithms to study average treatment effect or average treatment effect on a treatment. And finally, we can do sensitivity analysis to find like how the approach is valid. So the first medication that we were interested is diabetic modification. And in the previous talk on one of the talk, they mentioned about metformin. And the main reason why we are interested in diabetic drugs is to the fact that 60 to 80% of diabetic patients are at a higher risk of developing dementia. And that's why in this study, we were interested to compare the effect of metformin against sulfonylurea. And there are many research that indicate, okay, metformin really reduce the progression of the diseases. But in this study, since like there are many research validate the efficiency of metformin, we were interested to understand, okay, so when the patient develop dementia, for sure they have a prior comorbidity. So can we investigate the efficiency of metformin when the patient, for example, have COPD or when the patient have cancer or whatever? And based on the finding that we found, yes, for specific some group, like if the patient have breast cancer, metformin can show a really good effect in reducing or delaying the development of dementia. Same for CKD and COPD. While for the other, it didn't show any kind of any effect in terms of delaying the progression of dementia. The other treatment that we were interested in was anti-herbic. It's herpes infection disease. And there are many literature that indicate this disease or virus increase the risk of developing dementia. And that's why the first study that we did was to explore, okay, is it true? And based on the finding that we found when we compare HSV patient with control, healthy patient, yes, it's increased the risk of developing dementia. And then we focus on those HSV population and found like different treatment for this disease can have different impacts. Some of them will reduce the progression of dementia risk. In terms of the risk factor, so for dementia, we have different risk factors that contribute to the disease because it's complex disease. We have early stage, middle, and the late stage risk factor. And again, for risk factor, some of them modifiable, unmodifiable, or genetic. So when we are looking at electronic health record, we focus on modifiable, things that we can control. And one thing that really interesting about this risk factor, actually they are vary across continents. It's not like they are exactly same for all population and all the Alzheimer's disease patients. That's why we were interested on risk factor identification for early stage detection of the population or Alzheimer's disease patient. For second, it's if we manage to know like this person would develop the dementia after 5 years or 10 years or 6 years, whatever, can we understand which are the modifiable risk factors that we can control to reduce the development of dementia? And this will help also for a personalized care. So the main objective of the study that we did here is to do wide population screening. So again, we use electronic health record, the data that already collected and stored. So can we apply risk factor identification, machine learning for survival analysis to do this kind of screening and try to spot the patient that at a high risk of developing dementia and call them to start to introduce some kind of intervention? And for this study, actually, we use we use electronic health record, medical record data. We try to see how different feature or information can have impact. So we could test the demographic information, cognitive test, and comorbidity to predict if the patient will develop dementia or not. And based on the finding, we managed using, it's not clear here, it's one of machine learning for survival analysis to highly spot the patient that at a risk of developing dementia. And those are some kind of interpretation of what are the risk factor and the curve indicate the progression of the disease. And for sure, age is one of the risk factor. For sure here, there are some comorbidity. In terms of the early diagnosis, so everyone talk about Alzheimer's disease for early diagnosis of many diseases. And for sure, early diagnosis can help to provide a healthcare plan to reduce the disease progression, or which also save money for healthcare provider, and again, improve the clinical trial or selection of patients towards selected for clinical trial for finding a treatment for Alzheimer's disease. So the main objective of those study is trying to find a preclinical patient who didn't develop dementia, but the symptoms is already clear for early diagnosis. And in the first study, we use MRI image. And the interesting part of this study is that we didn't use the 3D representation of MRI because it's expensive in terms of the processing, and it needs a high performance computing. So we use a slice of the MRI, and the trick is we did some kind of feature transformation of the image which can help me to extract useful information from those images for machine learning or deep learning to perform well. And thank God, based on this idea, we managed to achieve a high performance in terms of classifying which state the patient is in and if the patient has dementia or not. So we reach like 98 to 99 accuracy. So current diagnosis of Alzheimer, if we talk about using MRI image, is actually expensive and it's not exist with everyone. That's why a blood-based biomarker can help in those process. And in this study, we start to focus only on gene expression and gene expression from the blood biomarker. And we try to build a novel AI model in which we need to incorporate some kind of biological information about the pathway of the gene that already generated by domain expert on the AI model. And we reach the AUC 79 for machine learning. It's acceptable, but it's not really good. And when we look at what are the features that the model use or the gene that the model look at, some of those genes actually based on calcium dysregulation, some related to mitochondria, and there are genes that related to depression, which is also a risk factor for developing dementia. So in the next study, we try to improve the performance because 79 is not extremely satisfactory, and we know clinical data can help. So we integrate all the information, and actually we improve the model performance toward 97 and 94 in terms of predicting Alzheimer cases using electronic health record with genome. When we look at the features, actually we notice like the top feature was age, which is expected, and then ApoE4. It's one of the top features that the model used to detect Alzheimer. And there are several genes that had been also reported as top 10 to indicate if the patient have Alzheimer or not. And those genes actually based on the literature already indicated that they are related to Alzheimer's disease. Okay, so now I will quickly talk about patient stratification studies. So in terms of patient stratification, it's a domain where we are interested to group patients based on the disease similarity or mechanism of action. And this domain actually helps for many aspects. For example, it helps for us to relate patients or group them based on a clinical and biological similarity. Again, especially like Alzheimer's disease is complex disease, and what it will work or whatever lifestyle changes that work for one cannot work for other. That's why patient stratification is really important, and also will help for precision medicine. The main objective of this study is using molecular or gene expression blood tests to group the patient and try to relate it to how this can impact the mechanism of action of different Alzheimer's disease patients. This is the study design. So first we use like a graph-based approach to group the patient or group the patient based on the similarity in terms of the gene expression. Then we apply like community detection to find those most related patients. We do matching based on the group that we extracted. So we match them based on clinical data, age, and their comorbidity. And then we apply gene expression analysis to understand the mechanism of action of those different diseases. From this study, we end up with two clusters or two groups that are cognitive normal, 3 MCI group, and 1 AD group. And when we look at gene expression or upregulated or downregulated gene, we notice there is some differences between the control and different classes of MCI. However, there one group that didn't show any, even though it's between cognitive normal and MCI, it didn't show any downregulated or upregulated gene. And when we look at the pathway or shared pathway between those different classes, we know only 5 pathways is shared between all, but there are other pathways that actually unique to each group. And here's some of the pathways that we found when we combine like the first control or control group with the others. So most of them related to synaptic loss. However, like here, if we have this group have DNA methylation here, the strange part that we keep noticing is viral infection, which keep pop up multiple times, and for sure, pathway for inflammation is already there. Due to the time limitation, it's done already. So a part of that, when we compare AD with the MCI, we can see different pathway had been pop up. some related to Golgi fragment, some oxidative damage. So all this work is actually based on already published work, and some of them are still under review. So you can read more about each of those studies. This is the research team that carry forward all those studies. And thank you so much. This is mine. Thank you so much.
Thank you, Dr. Shehi. That was outstanding. I do realize that the time is very limiting. I'm sorry. Yes. So I'm told that we just have one speaker before. Professor Raj Kalaria is going to be talking about post-stroke dementia. As a cardiologist, I see, so in our institution, we see 100% of the stroke patient, whatever the reason is in the cardiology clinic. So we co-manage these patients, at least from a risk factor standpoint. So again, for my colleague, the speaker, if there's anything that I didn't say, or you want to add anything, please take 30 seconds to discuss. So he is a neurovascular research expert, is involved in many clinical research trials. He is a physician in training. He holds several positions, not only in this region, but also in Kenya and many other countries. He is a professor. He also was involved in this kind of research for several years. Before I ask my colleague to come and speak, I asked the chairman to 5 to 10 minutes of Q&A at the end of the session, if that doesn't break any rule. So, Professor Kalaria?
Hello, friends.
Okay, it's remote. Okay.
Good afternoon. First, I'd like to thank the organizing committee, including Professors Marwan, Abdu, and Robert, for the kind invitation extended to me. I'm also grateful to Arlen for being patient. It is a privilege to present. I'm delighted and extremely grateful for sharing our work at this 9th International Conference on Alzheimer's disease and related disorders in the Middle East. My apologies I could not be with you in person, but I'm there in spirit. So I'm Raj Kalaria from Newcastle University. I've had a long interest in causes and substrates of vascular dementia, post-stroke dementia, and the interface between Alzheimer's disease and vascular dementia. Nothing to declare. I will focus on salient findings from the COGFAST study, which is Cognitive Function After Stroke study, which has been running for the last more than 20 years, I should say. And this is a study in elderly stroke survivors. The plan of my talk is as follows, and the main points will be on the clinical and pathological aspects which define what is PSD or post-stroke dementia. And these data are all derived from our prospective multidisciplinary longitudinal study, the longest study of the type, especially involving enrollment at baseline and then following up in the clinic right up to postmortem. So at the outset, I should like us to recount some history. The expression of hardening of the arteries as a cause of arteriosclerotic dementia came in the 1800s. Before that, of course, Thomas Willis had described apoplexy, as you see in the picture, as in the pendulum, so on in time. We went from a vascular cause, such as arteriosclerotic dementia, to Alzheimer's disease, the hype of that in the late 70s and 80s. And then I think all things were vascular dementia, and rather, I would say, vascular cognitive impairment. Many do not believe vascular dementia exists, and it is all contaminated with Alzheimer's disease pathology. However, in these historical developments, I should like to point out two seminal observations that were made in Newcastle. And that's why Newcastle is on the map, particularly the dementia map. And Newcastle has pursued dementia research for more than 50 years now. So these two seminal observations were that the burden of neuritic plaques at post-mortem, this insoluble proteinaceous material in the brain, was correlated with the cognitive status before death, particularly cognitive decline. And then the other observation was that the loss of tissue of 50 to 100 mils of tissue after a stroke was also associated with cognitive decline. And these were of much interest at the time and published in rather low impact journals. Besides, of course, BCI, we also, as you know, Newcastle is famous for studies on Lewy body dementia, and still continues. But we are still flying the flag for vascular dementia and BCI. Now, I think you already know that 70 or 80% to 80% of the strokes are of ischemic type. Among these, 25%, not among 25% or so are due to cerebral small vessel disease. And this involves small lesions, both cortical and subcortical, and a large proportion as lacunar strokes. The other 30 to 20% are hemorrhagic strokes, as you already know. And the individuals who have cerebral small vessel disease are the individuals who are going to live long, and then we need to manage them. So what are the risks and the features of stroke today in Western communities? These most recent data from the MRI Gini study involving some 3,000 scans show that the strongest, of course, risk factor is hypertension. This is not necessarily rocket science. And then others, including lifestyle factors such as tobacco smoking. Most of the strokes occur in the anterior circulation involving the middle cerebral artery and its branches. However, multiple small lesions are common, and many are caused by microemboli. You can read this paper in full, which was published in 2020. Very interesting. Now, the concept of VCI, which I mentioned in the historical aspects, has come of note and very topical. By vascular cognitive impairment, or VCI, we mean all causes vascular, both cerebrovascular and cardiovascular, and cognitive impairment also the spectrum from early to late in severe forms. And this can be rather heterogeneous, as suggested even in the earlier days. Years ago, there was a consortium that was formed, and VCI is all well and good. It also becomes obvious that it's cumbersome in terms of the clinical and treatment management aspects. So how does one deal with this continuous spectrum? So with the formation of this consortium, led by our Bristol colleagues, we devise essentially two categories in the spectrum of BCI, where there are mild or actual BCI cases and severe or major BCI equated to vascular dementia or frank dementia, under which all these different types can be placed. And as you see in the map there, features of major BCI or vascular dementia involve at least one cognitive domain and deficits in them, and particularly involving executive dysfunction, processing speed, and so forth. But the ADLs are also affected, of course. This is the current definition of vascular dementia, the conventional definition, which is really deficient, and of course does not involve memory, particularly amnestic memory, necessarily, like in Alzheimer's disease. These deficits, the current understanding of VAD becomes complicated, and as indicated here, perhaps it's only the tip of the iceberg that we see. So because there could be lesser degrees of impairment in all definitions of dementia, now not involving memory deficits necessarily, need to be looked at carefully. And that's why this all led to the concept of vascular cognitive impairment, or VCI. So this is where the field is now. How is VCI or vascular dementia caused? In this schematic slide, we have tried to present the different mechanisms as these cartoons come up. On one by one, you can see how the vascular obstruction causes the damage in the brain. Most of the terms are self-explanatory, but leukoariosis and hemorrhages are also of interest in terms of the VCI dementia scenario. Leukoariosis relates to white matter changes, essentially disruption or damage to the wiring of the brain, and of course hemorrhages can be intracerebral and subarachnoid main causes of bleeds to the brain. About 20% of all strokes, as I said before. The key question is what types of dementia develop after stroke. So previously, relatively small studies suggested that about 50% of stroke survivors will develop what we call post-stroke dementia. And then they were classified in various terms as vascular dementia or at least variants of that. And the rest were contaminated with Alzheimer's disease and alcohol-related dementias. So it wasn't very clear what the identity of post-stroke dementia was in the earlier days, because there were really no postmortem studies either, or a longitudinal studies, prospective type, to follow up. Some years ago, initially, we were very much interested in the link between hypertension and dementia and white matter change, and that is the wiring of the brain and brain atrophy. However, it became clear in time that to follow a fairly homogeneous hypertensive cohort prospectively in a longitudinal study would be challenging, because often hypertensives have several comorbidities, including diabetes, metabolic syndrome, etc. So the stroke follow-up question was also interesting, and particularly after the first stroke. And small strokes would be of interest, because these are the individuals who survive long. And then whether the question becomes whether they recover, they stay stable, or decline, or develop, and those who decline, what kind of dementia do they develop in terms of their impairments and dementia features. So we decided to follow elderly individuals who had had the first stroke established by CT and without impairment at baseline. And that's what you see in this map. And as you know, stroke can be a risk factor for dementia, and dementia can also be a risk for more strokes. Presents the design of the COG5 study. At baseline, stroke patients were cognitively intact. So their MMSEs and CAMPOG scores were quite high. And then from there, we could really then follow longitudinally what happens down the road in time, as it were, to stroke survivors. So as in the Newcastle strategy, we assess them from baseline annually after recruitment, and then follow up right until death, and obtain brain donations after consenting with the next of kin or the family. And we have collected now almost 100 brains from the original cohort of 500 patients that we had written down from 1,000 to 700 and then to 500. And so what did we find? The idea of the glass is that the positive side of the news first is that the glass is half full. So there was improvement. Several interesting individuals. In fact, even there in one patient who was skydiving, etc., and traveling and going on safari, etc. But many, very interesting stories that occurred. So there was clear evidence of improvement in a number of individuals after their small stroke, but many just remained stable and had also better outcome over a little time. The individuals with better outcome uh, uh, were it was good if the vascular risk factors were controlled, and that was a very important finding. Now the glass is half empty, and it was bad news if the stroke subjects or the participants in the study had two or more vascular risk factors, and if there was not proper or good adherence to the medication or control of the vascular risk factors. And executive dysfunction was quite prominent in these individuals, and you can see from the survival curves the progress to dementia and death were almost similar when you consider that if they had more than 2 or 3 vascular risk factors, then that was bad news. So the clinical message is very clear. And we also found that those who declined had greater volumes of white matter changes. They had temporal lobe atrophy as well as lower blood flows in strategic regions of the brain, almost akin to individuals who develop Alzheimer's disease. Longitudinally, in terms of trajectories for 8 years and 12 years and beyond, we found that they remained relatively stable after their strokes. But it was important to note that in the 3 years before they died or developed dementia, there was a steep decline in the trajectories. And so the clinical message is, again, very clear that the stepwise decline should alert the clinician to a possibility of impending vascular dementia or death. So the lesson here is strict control of vascular risk factors in stroke survivors. And the longitudinal data at 8 years showed that 25% developed dementia, even up to 30% at 12 years in the absence of significant Alzheimer's disease pathology. But medial temporal lobe atrophy was quite evident in these individuals. Our findings are within range of previous meta-analysis reported by Sarah Pendlebury and Peter Rothwell, for example, where in their systematic review they found the range was about 70 to 40%, with a median of around 10 or 12%. However, the report also showed that the recurrent events of strokes worsen outcomes. Our findings are also remarkably consistent with the term that's described as post-stroke cognitive impairment, incorporating worldwide data in the slide, which was reported in stroke patients of different ages, and the rates were slightly higher in younger subjects from both high-income countries and low-income countries. So what about the pathological correlates of post-stroke dementia? What do we find in the brain? The brains that came to post-mortem, almost 100, as I said, half of them had dementia and half of them did not develop dementia, and the degree and the quantity of vascular burden was about equal, but almost all of them had the small lesions and fell into class 2 of our classification that we published many years ago, akin to cerebral smoke vessel disease type of pathology. Small lesions, cortical lacunar infarcts, and white matter changes. And looking at infarct pathology, particularly in our postmortem cohorts, we found that although the sizes of lesions were almost equal in the post-stroke decliners, that is post-stroke dementia individuals, and the post-stroke non-demented, those who did not decline, but it was the location that was important. So there were more lesions and distinguished the two groups. So white matter disruption is a key substrate in the development of post-stroke dementia. Then structural imaging studies indicated that there was major temporal atrophy over the first 2 years in this cohort. And this we thought was consistent with the hypothesis that vascular lesions were unmasking or perhaps promoting an AD type of syndrome. And so this had to be tested pathologically. Before I come to the pathology, our arterial spill labeling study suggested that post-stroke decliners showed similar deficits in cerebral blood flow and hippocampal volumes as those diagnosed with Alzheimer's disease, where cerebral blood flow was reduced in the posterior cerebral artery and the lenticular striate arteries, territories. As these survival curves show that medial temporal lobe atrophy was a predictor of dementia, and not only that, but also to death, and very clear result between the decliners and those who remain stable. However, after carefully assessing the pathology in the postmortem samples, it was clear that the post-stroke dementia subjects showed cell atrophy in the general absence of Alzheimer type of pathology. And that this was both in the CA1, CA2 regions of the hippocampal formation. Thus, there were cell volume losses in post-stroke dementia patients compared to the post-stroke non-dementia patients, and this separated the two. And that probably explained the MTLA or the medial temporal lobe atrophy that I described previously. So in summary, we can say that almost 80% of elderly post-stroke survivors develop what we would classify or fit into the vascular dementia criteria, given the current scenario. And microinfarction was an important substrate that differentiated post-stroke demented and post-stroke non-demented groups. And so, in summary, we think that these changes all lead to disruption of the white matter and a disconnection between the cortical and subcortical structures through the loops. And this probably leads to cognitive impairment and then frank dementia. Slides turning to similar arms of the study in sub-Saharan Africa. We also are running rather still, the COGFAST study in Nigeria, cognitive function after stroke study in Nigeria. And I just wanted to share some data very quickly. Different diets, lifestyle factors, etc., and the other group of stroke survivors in Nigeria. But the findings were very interesting. This is also a longitudinal study. What we found in the Nigeria cohort, although younger, by more than a decade, we saw very similar clinical, neuropsychological, and neuroimaging findings, and including high frequency of vascular cognitive impairment, white matter changes, and even medial temporal lobe atrophy that was all explained by vascular effects rather than neurodegenerative type pathology, like an AD. Now, you might ask, how do we assess, for example, the neuropsychometry, and in this case, spatial orientation in some Android subjects who have never put pen to paper? We can use tests such as these, where a subject is asked to arrange the matchsticks in a precise pattern of a form, and then they can be scored. And you can see some examples where subjects are severely impaired in this cognitive domain. Get all of the data in this cohort. We found that increasing age was a factor in developing cognitive impairment or dementia. The level of education, as you see there, and that's particularly lower than 6 years, had a severe effect. And most interestingly for us, it was eating fish daily pre-stroke had a profound protective effect of at least 40%, and this is something important to consider. longitudinal data thus far, after 4 years in the COPFAST Nigeria study, we also found that previous stroke was detrimental and higher education was protected. Again, the proportions of cognitive impairment after stroke did not change much and was around 30 to 40%, as you see in the data here. And besides consumption of fish, data from the SILEN study in Nigeria, also involving stroke survivors, suggested that eating leafy vegetables was also protective of developing BCI after stroke. So again, an important message to consider in terms of our diet. To bring the talk to a close, I'm using this working hypothesis and want to say that vascular changes leading to white matter lesions or white matter changes may then trigger these other pathologies that you see down the route. And depending on the duration and degree of the initial impact and modifying factors, it may lead to development of these pathologies in the spectrum of VAD and AD, but particularly the risk factor for hypertension is of note. So looking after your blood pressure is very important, as you see here. And I'm just putting a rhetorical question to all of you. How many of you do you know your blood pressure? Well, there are such individuals in the community walking, talking, and you can see that they could be highly at risk. And this is one of our African subjects. Controlling vascular risk factors may also reduce the burden of dementia, including post-stroke dementia, vascular dementia, and this may be the case in our MRC CPAS study published some years ago. Role, our work also suggests, especially that we always include comparison groups such as those diagnosed with Alzheimer's disease, and that small vessel disease, particularly arteriolosclerosis, is an early change among the biomarker profiles considered for even Alzheimer's disease, we think. We would modify these trajectories previously reported by Jack et al. As shown here, that SVD is probably a very, very early change before all these other biomarkers increase in time. It's to say this is what we really need to do. Look after your blood pressure, leafy vegetables, exercise, stop smoking, and if we're not advocating a drink, but if we do drink, then it's moderation as well. We can say that hypertension is a key vascular risk factor to control. Microinfarction is an important substrate. Stroke survivors develop largely vascular dementia, 80% of them. The other 20% have mixed pathologies. And there are implications for early vascular dysfunction in all dementias. I appreciate your invitation. Individuals.
So the next, we're going to have a discussion with our guest from Turkey. We're going to talk about, what is it here? There's her slides. Sorry, I have a presentation first. I'm looking for my slides. Thank you. So this is not completely true because there's also skin biopsies. I'll get back to that. So I thought we used to review different fluid biomarkers. By the way, for
just a comment on the previous presentation, which was excellent. We think that BD tau, brain-derived tau, is a very important biomarker for vascular-related dementia. So the use of CSF biomarkers in Parkinson's disease is important because obviously we're looking for first to characterize this in clinical trials. If we have an ongoing clinical trial, we need to know what we're doing. We can conclude, as you may have noticed, that both the clinical diagnosis of PD is very difficult, especially in early disease, and the biomarkers then become kind of essential to find a real case. We have to find a target engagement in man, and the pharmacodynamic data then is essential. The downstream effects, the biomarkers indicate an effect on pathology, and the proof of disease-modifying drugs by biomarkers is also important. So when we look at alpha-synuclein, it is a cytosolic neural protein that is involved in vascular function, but also in neurotransmitter release, and is important for cognitive function. So it has healthy effects. However, alpha-synuclein does aggregate in some people, and they are found in Lewy bodies, which is associated with several different neurodegenerative diseases, most commonly Parkinson's disease, but also disease of Lewy body and MSA, multiple system atrophy. So first we look at the Alzheimer's biomarkers because we would like to know how they are behaving in the Parkinson's disease. And here we have looking at 5 different biomarkers in the CSF. And what we see is that these 5 biomarkers work very well in Alzheimer's, but are really unchanged, largely unchanged in Parkinson's disease, MSA, and DLB. So if you divide them up, the Aβ42 unchanged, the total tau unchanged, the phosphorylated tau unchanged or overlapping, and the NFL does change for MSA, but not so much in Parkinson's disease, and perhaps a little bit in DLB, more in later stages. Again, if we look at a review of all the biomarkers for Alzheimer's, lots of different studies. We find that the core AD-CSF biomarkers are normal in Parkinson's disease. So the use of them is really to exclude concomitant Alzheimer amyloid pathology in our patients, because obviously they can coexist. And CSF NFL is normal, but is high in PSP and CBD and MSA, which is valuable to exclude particularly atypical Parkinsonian disorders. If you look at large studies, we can see that, if we look at many studies, we can see that the if you measure alpha-synuclein by itself in CSF, it's slightly decreased, but 1 standard deviation, so it's not much. So can we use it anyway? Here's a paper with 9 CSF biomarkers and looking particularly at a typical Parkinsonian syndromes, which are perhaps even harder to differentiate, and they find some differences in some of these biomarkers. However, it's very hard to do 9 different fluid biomarkers, so this would not really be practical. And the data was interesting, but as I say, this is probably not going to translate into the lab. What else with alpha-synuclein in CSF? Well, in Creutzfeldt-Jakob disease, you can see that this increased quite a lot, but we also have other biomarkers there, so maybe not super interesting as well. There's another paper on that. We can look at longitudinal changes of alpha-synuclein in CSF, and it may reflect Parkinson's disease progression over time. There's definitely more work that needs to be done here, and the plots are quite scattered. Yeah, it's just more of the same. So then we go over to looking at alpha-synuclein oligomers, which are increased in Parkinson's disease with dementia with Lewy bodies, and compare that to Alzheimer's disease. And what we find here is that the oligomers definitely are increased. So as we reviewed earlier, the alpha-synuclein by itself, the monomer was slightly decreased, but the oligomers are increased, which kind of makes sense. They are oligomers. And here are some of the publications, again, very small increase really. So there wasn't much there. If you also look at oligomeric as well as the phosphorylated alpha-synuclein, could that be used? And we see here that, again, very much overlapping results, and the area under the curve is not satisfactory here. So the search goes on. We know that from prion disease, or that the self-propagating misfolding proteins occurred broadly in all neurodegenerative diseases, or most of the neurodegenerative diseases really. Obviously, the dual proteinopathy of Alzheimer's disease with amyloid as well as tau. There is a specific tau misfolding in Alzheimer's disease that is not the same as the one that occurs in other more aggressive neurodegenerative diseases. And then you have the tau only misfolding, which happens in CTE, in Pick's disease, in CBD, and PSP. And then, of course, now the alpha-synuclein misfolding in Parkinson's disease and Lewy body dementia. So could we use that and somehow to also make an assay? And there is such assay that came about 9 years ago. And it is an assay that measures the accumulation of misfolded proteins, and maybe not the same as what happens in the brain, but it is a similar way of doing it. And it's a seeding assay, so you put the seed of a misfolded protein, and then this was the first paper that was published on this. And this is how it looks. And there is some false positives, but largely this works really well. So the black here, or the blue, are Parkinson's disease. And the more seed you put in, so the more left you are to this graph, the more quicker the misfolding happens, and the quicker your readout is. Not surprising. And now the area under the curve is really quite good. and we see good separation. Not everybody. There are some false negatives, as you can see, and there are some false positives, just as many assays have. And this is more of the same. So the normal controls, you see, they're false positive. And Alzheimer's disease, the false positive. DLB, a little bit later reaction. And then the mixed Alzheimer's as well as DLB. And the PD reacts faster in this particular assay. And then you can find this across alpha-synuclein Cs across different neurodegenerative diseases. And I think the previous slide was quite good at showing that. Here is a big study in Sweden where they looked at what is Lewy body and AD pathology and cognitive unimpaired. And you could find some Lewy body disease in the unimpaired. You could find some amyloid pathology as well, and we know that, and there was some combination, but obviously in the cognitively impaired, this increases quite a bit, as you can see. There are ways, you don't necessarily have to go for CSF, you can also go for skin biopsy. And here's a method that combines the two, so they use a skin biopsy and then do this RT quick assay. It was similar results as the CSF. And then we have a blinded, sorry, this was the same study, this blinded assay, so it was a similar. Then there is one lab in the United States in Arizona that was founded by some people from Harvard that looking at so phosphorylated synuclein in skin biopsies. And this larger study, they had 223 that met consensus criteria for synucleinopathy, and 120 met criteria for controls, and they had a very high numbers of area under the curve and accuracy. However, there's several critiques about this study, I would say, and I'm soon finished. And then also you can do this RT quick in serum, but there's only one publication here in Nature. And there are structural differences as well. Thank you.
Thanks so much, Dr. Ham. It's amazing.
Thank you. Thank you, Professor Frickman. I wanted to have some summary of work that was done in Turkey on 37 patients with PDD. Do you want to summarize some of your work?
Can you hear?
Yeah,
it's
I can hear
better
it.
now. Okay,
It's-
thank you.
Yeah.
And thank you very much for the organizing committee for
Yeah.
for their kind invitation.
Yeah.
I want to summarize our
Just a brief summary of the work.
brief summary.
Yeah.
We wanted to check if at the baseline PD patients, when you do the CSF and check for the biomarkers, if the low CSF A beta 42 predicts more Alzheimerization pathology. I mean that if the patients you have the drug naive PD patients at the baseline, if they have low CSF A beta 42 levels at the CSF, we checked if they have more memory problems, primary memory encoding problems when they develop dementia. We know that in the clinical pathological studies, if they have low CSF A beta 42, the cognition will get worse. Or if you check at the baseline, the low CSF A beta 42 predicts more memory problems at the baseline, not at the when they develop the dementia. We want to check that at the baseline low CSF 42 and when they develop the dementia, if they have more memory problems or not. I mean that the low CSF 42, A beta 42 predicts a typical cognitive profile in PDD patients. And we subdivided the patients into two groups, two types subdivision. Like dichotomously, we checked the CSF levels of A beta 42, and we divided the patients dichotomously, and also we made it with tertiles. And in our study, we checked by two types of quantification CSF A beta 42 with ECL and also with INO tests. And at the end of the study, we couldn't find any association with the baseline CSF A beta 42 levels and the specific profile of the cognitive impairment when they develop dementia. So we argued that maybe we suggest the amyloid pathology does not predict a significant cognitive profile. It's not a trigger, but maybe it will interact with alpha-synuclein, or maybe it represents comorbidity.
Thank you. I have an early publication on this, but about half, if I'm not mistaken, and I'll take this for you, about half of PDD patients have amyloid pathology and half don't. What is your experience on that? Half of the PDD patients have amyloid pathology and half don't. Is that your experience as well?
Yes.
And what's your experience on that?
Yes, that's true. Yeah. So especially in later stages.
Are there questions from the audience for anybody? Yes, Dr. Freeland.
Dr. Calaria still here?
No, I don't. Is Dr. Clary still on?
In any case, I'd like to submit an appeal to everybody that we need to move on past describing what happens to patients. Not that we don't have to do this, we should continue to do it, but the most important thing is not what goes wrong with stroke, what goes wrong with dementia and Parkinson's, but why. Like hypertension is not enough of an understanding of these diseases, of this vascular diseases. What is the cause of hypertension? I'm not sure we have a better understanding of that than we did 50 years ago, when we thought it was caused by stiffening of the vessels. So with colleagues in Japan, particularly Masafumi Ihara in Osaka, we've shown that the microbiome in the mouth has important influences on vascular disease in the brain. And it's already known that periodontitis is a risk factor for stroke, a risk factor for Alzheimer's disease and heart disease also. We need to add oral health into our mechanisms of dealing with risk factors for these diseases. And if I could just ask a question to Dr. Frickman, is it assumed, I imagine it's assumed that the alpha-synuclein in the skin is coming from the brain. Is it possible that it's coming from the skin and going to the brain?
And it's a good question. We don't know, but this is obviously possible. There's phosphorylation going on in other parts of the body as well. So, but we normally see it in the brain. The skin biopsy path is to me is not as well understood or well characterized, although these very prominent researchers who might know some of them personally have done this work. I have several criticisms of the work, but we can talk about that privately. Maybe.
Other questions? Yes.
Okay. Thank you. Actually, this question, I would like to say it when Dr. Laham was talking about the augmented learning. And then I will bring it now in another way, because I think it's the same. I'm always thinking about the role of autonomic nervous system in all those degenerative disease in the brain. And there are some studies, as I read about it, about the autonomic disturbance in Alzheimer, different than the pattern of autonomic disturbance that start early also in Parkinson and other disease. And I think that is the correlation. Maybe there is autonomic disturbance. The autonomic system is correlating between the brain and all the gut, all the body, from the toes to the eyes to the retina to everywhere. And I think we have little area that it is not really understood between specialties also. And when we have dyspepsia functional, that means it is coming from the brain. Cardiac palpitation or high blood pressure episodic coming with stress, that means it's coming from the brain. I think this is the autonomic nervous system, which may be correlating what you are asking. I think, and what's your opinion now? It also proof here also, what do you think?
I trust there's something similar that we find in Alzheimer. It's the same applies for neurodegenerative disease. Even there's a bacteria in the saliva, like gingivalis, is related. So now my approach has been multi-organ approach for people who are coming with brain fog, especially at earlier stage. That's very reasonable question. Regarding the dysautonomia, is it a result or is it the upstream or downstream? So now we started doing MIBI for all. I'm doing MIBI. So I'm having a cardiology, Dr. Haluk, Dr. Saner knows him. I'm doing on all those DLB doubts because CSF was sometimes not enough. I'm stuck if I do CSF and it was amyloidopathy. Should I give lecanemab? But this guy, cognitive and memory pictures suggested more of subcortical or basal ganglia disease and motor system. So the phenotype plus CSF are still not helping us. So then I went, okay, let's do the MIBI, and maybe also cardiac test help me sometimes. And then a PSG, then I have to ask our pulmonologist. So that's fascinating. So we need to know which causes which first.
Exactly. There is central nucleus and peripheral. I don't know where is the problem start.
But we do know that it involves multi.
So I have a question for my colleague. Some people believe that PDD and DLB are the same disease and some don't. I think they're separate or they're overlapping, but not the same. What are your thoughts, and how does that biomarker data inform you?
Yeah, thank you very much for this question. Of course, this is the big deal. We don't know if it's the separate ones or the same. I think it's not almostly separate, but of course there are some kinds of differences happens in the brain. So much more amyloid pathology happens in DLB patients and in the earlier stages. Also, the CAA also accompanies with these pathologies. So we cannot divide it, both of them, into two different diseases, but there are some similarities, a lot of similarities with them, but also a little bit differences, like you can see in the clinical. If the amyloid pathology is too much, the dementia starts earlier, it means that. But if the amyloid pathology is much more lesser, and also alpha-synuclein pathology is much more worse in DLB pathology, in DLB patients in the earlier stages. So there are a little bit differences, I think, but it's almost at the same part of the maybe schedule.
And then Dr. Allah.
Yes, Professor Zainab. Yes, I had a question for the cohort that you studied with the CSF. So you looked at the amyloid, the beta 42. Did you look also at phospho-tau 181 or total phosphorylated tau?
Our study was, we collaborated with Park West study, the first 10 years of the results of the Park West study, but we didn't check, for this study, we didn't check the phospho-tau levels, but they looked for the patients' phospho-tau levels, but in our study we didn't use that data. We just used the amyloid part.
And they were followed up for how much time?
We used that for the first 10 years.
10 years.
10 years. Yeah. Right. These are the 10 years results of the Park West study.
Okay, because I was wondering, because amyloid is often asymptomatic, and then you have the not much cognitive changes with amyloid, but often it's correlated with phospho-tau. I was wondering if this could be an explanation.
Yeah.
Thank you.
We have one more time, Dr. Allaham's question, and then we'll go into a break.
First, I want to thank my colleague for daring to talk about why, because it's not a la mode to talk about why. If you say why, it's idiopathic. So please know that I respect you for since medical school. I've been talking about this, but that's not my question. My question is to go back to the amazing work that you discuss, a cardiologist from outside who knows nothing about the specialty. If I tell my mom to have an LP or to have a nuclear scan, etc., it's very, very unlikely she would have been interested or she will be interested now. Dr. Marwan and the team are very aware of tons of research done on breath tests in Cleveland, Ohio specifically. I got so interested in this when I heard about it from one of my colleagues in Ohio around 6, 7 years ago. And maybe I'm a complete ignorant person, but for my colleague in Turkey and for all of you, something as simple as is it true that it has 90% accuracy? Is it true that there's a publication last year? I would like you to bring this up because of ease. يسروا ولا تعسروا. Thank you.
Is that for me or?
Do you want to? So there's a company called Picamole out of Canada that actually has a breath analysis of your particulate matter and shows pretty good sensitivity and specificity. But early interest, I haven't seen it move forward. Have you?
Yeah, so this is very difficult to standardize these kind of breath tests. So I've been involved in that in a very early stage at MIT, and when we started this about 12 years ago, this was amazing. It was in cancer, and it hasn't really moved forward meaningfully. Not that it can't be done, but it is from a laboratory and standardization perspective is very difficult. So I think it's important for clinicians to recognize just how difficult it is to find a robust test that is repeatable. So what you want is a test that reads the same day after day after day after day. Like p-tau 217 is you take it up from the freezer from years ago and you get the same reading on the same assay. This you do not get with this metabolomic assays, unfortunately.
10 seconds just. Remember the GI colleagues, how much they rely on the test. Dr. Marwan, I ask you kindly next year to have this part of the speaker panel. Thank you very much.
Thank you.
Thank you, everyone. We will be doing dementia debate, meet the expert solution for the Middle East and the MENA region. We got all the experts, so please join us after the break. Thank you. And if anyone has solutions, also welcome at the end of the session. Thank you so much. And we will be having now the awarding plaque now for the speakers. So speakers, please come over here for pictures. Now, for the morning?
Speakers for the session.
For the session, please.
I ask the representative Lily and the National Reference Laboratory to come to the stage, please. Doctor, we're going to give the plaques to the sponsors.
Sure, of
Okay.
course.
We want to thank the gold sponsor from Lilly. Thank you for your generous support of this conference. We hope you'll continue to support this conference. We're already discussing the next one. And she is the new incoming chairman of the organizing committee is Dr. Hanad. So hopefully you'll support it in probably 2027. So thank you. Thank you. Thank you very much. Thank you. Thank you. Thank you. And National Reference Laboratory. No, you need this. National Reference Laboratory, if we could have you come to the stage, please. Anybody else? Oh, Asa is here? Oh,
Anybody? Yeah, Dr.
Brinkman's from
Yeah,
the
it's-
National Reference Laboratory?
It's not you represent.
Yeah, that's fine.
Spot. Is that
Together.
together?
Thank
Okay.
you.
Great. He was here, Dr. Steven. Dr. Steven? Come on. Steven, did you? Steven is here.
Oh, Dr. Stevens.
Yeah, please.
Dr. Stevens, if we can get you to the stage, please.
Well, is it always here in Algarve?
It was Cyprus with this town. No problem. Asking for it.
right? Yeah, that's fine. Yeah, yeah. Okay.
Here's yours going to be the picture. This one.
Okay. Oh, okay. Okay, so just the green one.
Our esteemed attendees, I wanted to thank you to stay that long and on this weekend to attend the session. So today we are having very distinguished experts. We're going to discuss dementia in the MENA region, challenges, landscape, solutions, and we're going to come up with summary, and everybody's going to share their experience, their challenges, and we will have Q&A. So I would like to have Dr. Ra, Saudi Arabia, and Dr. Nasser Zubaidi, please come to the stage. And Dr. Nasser Zubaidi from UAE, and Dr. Mohammed Hatu also. And please help me welcome them here. So, Dr. Did we miss any geography? You're expecting also Oman and any other country that I miss here. I'm happy to have him on this chair. From Bahrain, yes, if somebody from Bahrain, that would be great. Okay, Qatar, we have Qatar. Okay, so let's start on the landscape. We all agree that it's rising fast. We don't want to embark on that much. And let's see how much, start with Dr. Nasser in UAE, how much did we do and what is needed urgently now to be done? Are we detecting well? And who should detect? Who, when, and where? So is it psychiatrists? Is it primary care? And how and where? Which care setting?
Assalamu alaikum. So, first I want to point out that Dr. Hanan has actually pioneered a memory clinic in Abu Dhabi, and we're following her steps now. With the help of Sakina Mental Health and Saha, and Pure Health, we're opening a network of memory clinics. However, I do find specifically in Abu Dhabi that we struggle in early detection. A lot of the pen and paper tests are language-based and culture-based. So translating literally does not work. Something that I stopped using completely is the Boston naming test because of all the items that are not culturally known to our patients. The other thing is that we do still struggle. So I'm mentioning the challenges so I can get advices from our colleagues. It's the system. So basically, the memory clinics, we decided to have open doors because we don't have a clear referral system. Just like in other parts of the country where a person would come through a family physician, they'll get some labs done, perhaps they'll be started on a memory pill or so, and then they'll have to wait for some time to see a memory specialist. So that's not the case here. We don't have a clear pathway. So we're kind of running parallel rather than running together or in sync.
I agree with you. So that if I understood it well, sex problem with who does what and what tool, we still cannot say talk about MOCA and how can we make it more culturally sensitive with the vocal skills. And we've talked about also time, the physician timing, and how about leveraging digital tool in Saha? Did that help? Did you try it? Did it help? To screen, so family would do that, like something like Mocha Express. Is that correct? Yes. So
With Khalifa University, we're running a few studies looking into digital tools, but they haven't been validated yet.
Right.
There's a major issue that the current population that comes to the clinic is illiterate. So
and they are not computer savvy.
Exactly.
Right.
So, but such studies are going to serve us in 10 years or so when the patients who come into the clinic who are now in their 50s, they're
the baby boomers.
Exactly.
So see, with dementia, we're talking about spanning all the age groups. And I have the same story. I see, when I was practicing in New York, most of my patients come at MCI level because the nurse practitioner goes screen them. Part of the Medicare wellness, like you do mammogram, you do screening. So the nurse does that. So that's why the question, should we embark on people like a registered nurse or nursing due to the time? And once positive, they send to us. So this is something maybe might think about it. Is it feasible or not? I started doing that in the clinic as well. So this is something. The other thing is that when I talk about dementia, I see from Reisberg stage 0 to 7 here in UAE. As opposed in US, I start, like it's a different practice, and you've been all in North America, like Canada, and you've been in also Saudi Arabia and also Qatar. I'm sure you got the experience, and how can we leverage it here and give our expertise. So I thought we are actually leveraged to have more support. But we need to, what we call, to hunt for talents. So I've been using, I've taught a lot of my staff, they do the screening, and when they are positive, they do that. At primary care, the same thing. So maybe thinking about it, because I don't have time to screen everyone. So this is true. And when they are positive, I can do that. So I would ask now Dr. Roa, what's your take on that?
Thank you, Dr. Hanan. So I think I've been thinking about all of this for years, and this is where I came up with the idea of having the pathway in the Eastern Province in Saudi Arabia. So I'm privileged to work in a Ministry of Health hospital on a tertiary level, and I'm privileged to have all levels of care under one umbrella. So the Eastern Health Cluster, we have primary, secondary, and tertiary care all report to the same administration, which helped making the pathway. And I tried to answer all of those questions in the pathway. I'm sure I did not. Well, not all of my answers are 100% correct, but this is what I've done. I truly believe that it should start with the primary care, and this is where our brain health clinic is now established. So we established, yes. We established a brain health clinic in the primary setting. I truly believe, and I strongly believe in capacity building. So these are family physicians who have no experience with dementia, but we're conducting regular workshops. We had one in April, and we're having, in February, and we're having another one now in April, next Wednesday, where we train family physicians on early detection. Now, early detection is really tricky, because what are we detecting and what tools are we using? But I always try to leverage on what's available in the area. So I know, for example, RUDAS was validated in Oman, in Omani population, and we're probably close to the Omani population. So I use RUDAS for those who have less than 5 years of education. And I use MOCA for those who are who have higher or more than 5 years of education. I refer to Dr. Taim al study where he did the normative for MOCA in Saudi population in Riyadh, and we chose, I arbitrarily chose a cutoff of 24 instead of 26 for our population. So I use a cut of 24 instead of 26. We might end up with more false code positives, but that's fine. Now, I think our major struggle is really in functional assessment rather than cognitive assessment. In cognitive assessment, you can just do a validation study and say, well, our cutoff is 24, 22. But the problem is in functional assessment, because our elderlies, for good intentions, do not do much. And therefore, it's almost impossible to pick up people early. I have people who come really early in the course of their disease. I see them every 3 months, 6 months, yet I really miss the time when they convert from MCI to mild, and I suddenly realize that they are moderate, and it's because of they simply don't do a lot of instrumental activities of daily living. And I think, to me, that's the biggest challenge in our area.
I agree with you. The same thing as a neurogerontologist. I felt the IADL is useless, the one we use in US, because you ask the lady, do you cook? No, I don't, but she has a chef. Do you drive? So you lost your driving skill? No, I've never driven. So how are we going to assess her skills? I usually ask her what was her job and hobby. She'll tell you I was tailoring, so I'll ask, and I'll send her to occupational therapists sometimes to challenge her with tasks, because basically you need to know whether how much they drop from their baseline. This is dementia is not comparing them to somebody in another room like IADL. We're not judging them by number. We're judging them by their function and their baseline. And we talked about the prayers test. That's the prayer in the culture. We've been having like luxury to have a side talk. I have a test lab validated called the prayer test, and we can launch it and see how does that work. In prayer, in Muslim prayer, you need to be attentive to the time. So you're oriented. If you don't hear that. So you know this is Dhuhr and Asr and Maghrib and Isha. When the patient comes and say, what did you pray? And you say, I prayed Isha, and he is now in mourning. I just right away, I know this is very advanced. Right away, without, especially, we have to have a non-offensive approach. Another thing is it's still stigma, and it's a part of dignity and honor, like you're touching somebody's dignity. I'm here to be tested. So we'll talk about this. We can go on and on. So the indirect test, the prayers test, helps a lot. How was your praying? Where was? And you have also the orientations, visual spatial to the Qibla, and then you have the executive function, and you have the frontal lobe tracking the Ruk'a number. I've seen a lot of sometimes physicians send me. I always forget which one I did. I need a Ruk'a Talta or for the first and the third. I have, so these are really good. And also the language and flow. A lot of family will tell me he will be mixing Surah Al-Fatiha. I know when he try. So these are all, and this can be done by family. So I usually give it to family because you have to witness it, or occupational therapy. You cannot have everybody, pray in your room and plus do their other things. So this is something we might, especially, so we have different generation also. We have the baby boomer who are retiree. I have a lot of engineer and PhD in UAE. They are now in their 60s and they started after retirement. So these are different approaches. We cannot say one cognitive tool and function fit all Emirati, because now Emirati for each decade they're really rapidly changing. But we have to handle those like treasure, the elderly that we have with a different tool. And I found the functional tool is better for elderly. As doctors, I am, Dr. Zubaidi, we see a lot of geriatric. So I see stage 5 and 7, as opposed 6 and 7, sorry. 6 and 7, usually in New York, they are nursing home. They're not clinic patients.
Recording in progress.
I'm getting patient on a stretcher because just they get confused. This is we don't have some.
I'm not surprised.
Yeah, and to assess their cognition, they only know what is your name. Like this is also talk about models of care, utilization, the right service, the right setup, and this is something I would like to ask also our also colleague Dr. Mohammed. The same your comments on, and what's your suggestion?
Sure, but before that, I hope that miscalculating the Ruk'a is not a sign of dementia, so it happens with me every day.
No, it happened every time.
Everybody.
Yeah, sure.
Yeah, I think it's a work in progress. I think I agree with my colleagues. Raising awareness for the physician is important, but also raising awareness for the family. It's very common. When you ask about does your father has any memory problem, they will say no. When you start to ask him the memory clinic, then they will realize that he have a memory problem. So it's very important for the family to be aware that their parents or know how to ask them these awareness questions, not to just say this is the normal aging. And if they are aware, and then if they know that there is treatment available now, that will make them ask the first physician, then the second physician. Still, even in Hamad and Qatar, and all of our physicians are picked, we still have people who do not believe in the treatment until now. So awareness for the family, awareness for the physician.
Wonderful. And that does not start in neurocognitive clinic. So when they come to me, they already have a problem.
Yes.
So that goes to Dr. Roa that they should be addressed at the primary care, not tertiary or quaternary care. And this is the role of awareness of primary care. When I ask them why we don't do that, and and if you ask the same thing, we don't have the time. If we find something, we don't know what to do with them. They're offended. The family are, why are you asking? Or so now we are suggesting implementing CARE program. CARE is this CARE stand for kicks. K stand for kick. We can discuss it in different in special conference how to you can Google it. I can give you the link. Kickstart the conversation at the primary care. It's just a conversation. You are at risk. You're diabetic. I will share with you Cleveland Clinic pathway. It's derived from CARE program and would be something we can discuss it as a model of care. So when the primary care, if he is busy, he can give the 88. 88 is well-validated tool, collateral neurocognitive history. Or the Q4, and there's something called, and actually Q4 or 88. 88 is shorter, and it's actually, I draw a plot, it's similar to, it correlates with MMSE. It's an 8 questionnaire. Ask the family, and it's prerequisite before they come to see me. So anybody is coming to see me, I know if they are 8 out of 8, they are very advanced. It's more than 3. So please, just have a look at it and tell me maybe we can have it piloted and validate that. I think this is the simplest way to validate 88, and it's very transcultural. Before we jump to MOCA at the primary care and MSE, because we're asking our colleague something they might not have the time. If they are positive, I tell them send to me. I will do that. And if you feel, and some of them they're happy, they've been certified in MOCA. I have two of them. They said I would love to work. In cognition. They love to work, but in cognition. So I have, have them with me. So this is something, a solution. What would you think about? And it's not like, collateral history, and actually dementia is collateral history, right? So that's it. Second question is, do you have a staging and tailored proper, setting of care tailored to staging? Do we have it on the Ministry of Health? So when you have the Medicare, if somebody's 7 or 6, he should be followed by certain setting. He should not be in the clinic. Clinic should go to him. If my dad's refusing to come and I have to grab him and get him dressed, and he's offended. I have a dad at age 100. He barely goes to the urologist. He was started to get at the end. He lives up to 100, God bless his soul. But I feel as a patient, I feel the patient. So I do the digital visit for them, and I send them now to Sakina, which is very blessed program. But we still need to have more manpower for that. I know you're overwhelmed. So this is something we suggest. Do you have something like that in Qatar, Saudi Arabia, and like Dr. Zubaydi? You want to talk first about your experience?
I just want to agree with what you're saying. What we're doing now is that we're trying to reach out to each other as colleagues, and alhamdulillah, we are collaborating. I'm doing the same thing with family physicians and home care. I'm calling them, telling them, look, I have this patient who has dementia. I'm calling rehabilitation specialists, telling them this person needs OT for falls and PT at home to preserve whatever strength we can preserve. But it's a lot of personal efforts. We still don't have the network of dementia care.
Yeah, we need to replicate Dr. Nasser anyway, and the staff. So the other thing is, which really here I am bombarded with, is the comorbidity that really worsen dementia outcome. And I'm going back to my board of internal medicine in managing all of those behavioral problems, because I'm very antipsychotic. So I minimize, I deprescribe. Even in New York, I have colleagues who overprescribe. I know you spend more time, but when you know that he is having UTI, his CHF is getting worse, I tell him go to the cardiologist first and call. So I know that his BNP is going up or his electrolyte. So we know a lot of encephalopathy here. I'm seeing in the practice superimposed on dementia that the comorbidity with diabetes and stroke and all that, and obesity and untreated sleep apnea. So what is so as a psychiatrist, this is a different scope. For me, I have it's very challenging. So you need to have internal medicine working on comorbidity because he's treating only his brain. He needs somebody to treat all his body part. How did you handle that? Anyway.
We've done when we designed the pathway is we involved people from all disciplines. So we have the head of home health care, part of the committee. We have a geriatric psychiatrist, a geriatrician and sleep expert with us in the pathway committee, and we've designed the pathway where each patient is referred to the appropriate, so each stage is referred to the appropriate level of care. So those who score, we're using BADL, Bristol Activities of Daily Living, as a population segmentation tool. So we segment people based on their Bristol activities. Again, we chose Bristol because it was validated in Saudi population, so we have validation for that. So those who score in the mild range are referred to the memory clinic to have better assessment. This will fast track their ATT treatment in the future and so on and so forth. And those who are in the later stages, equivalent to 6 and 7 on fast staging, for example, are referred to home health care. So they are directly referred from the primary care to home health care.
Sure.
So they don't go through the hustle of the secondary, tertiary
That's good.
care.
That you have a score
Yes.
above what above
So
which you
again-
do different service. That's wonderful.
Yeah, so
And
again-
that's what we need here also.
Again, the segmentation was kind of arbitrary because, as you know, Bristol Activities of Daily Living, there is no specific range for mild, moderate, severe that you can just stick to. But we said arbitrary, those who score less than 20 are mild, 20 to 40 are moderate, more than 40 are severe. And based on that, now I completely, and I always tell the team, we completely understand that we might be wrong with those numbers, and that's completely fine. We can refine those numbers later on. But at least we have something. We have something to go back to and say, well, at this stage we'll do this, at that stage we'll do that. And I think it's a good start. I'm not sure where this is going to lead us, but
Wonderful. So also this is actually really helps. So for instance, stage 7, you have the stage 7 when they are almost bedridden and they have non-intelligible speech and they are incontinent to stool and urine. They're totally dependent on care, and they are based on the 7 A, E, B, C. They are actually, we have something called not here, which is like maybe something we should mimic here. We have geriatric palliative, where the quality of life that matters. The family have understanding that we can have him suffer less, have a blissful life, maintain his dignity. Where you can also give benzos. I'm against benzos in my practice, but I say this is stage 7. He's agitated. Let him. He's in pain. It's okay to give morphine. So they are in pain. They have chronic illness, and he doesn't speak out. So we need somebody to address those. So something like that. And now, Dr. Mohammed. Sorry.
I'm happy that we have more treatment for dementia now, but also I'm worried about the future. As they say, if now there is a disease-specific treatment, so we expect that the numbers of the patient who gonna come to our dementia clinic gonna increase significantly. For example, our MS patient, when I came to Qatar, we have like 180 patients because as soon as the treatment improved, we have like 2,000 patients. Then this big influx, you have to deal with it. Dementia patient take a longer time. And actually, it's been ignored for somewhat. Like in Hamad, we have a stroke educator. Any patient who had an acute stroke, the stroke educator will speak with him. Any patient with MS, the MS educator. Anybody with epilepsy, we have epilepsy educator. But when it comes to dementia, we don't have a dementia educator.
That's perfect. Yeah, so that's a perfect point. I want about the therapeutics. So we're in the diagnostic part, but thanks for bringing that up. So so we'll go back to that part. So we said about what is the problem? We have problem, right? And how are we detecting? We know that there are tools. We need to validate that functional and staging wise for proper and where we talk about where which care setting we have to diversify the case setting care setting based on each staging and expertise for that team. And this way actually we utilize our government support properly because we have tons of money in this country, but we are really optimizing utilization. That's the key. So it's redundant to have somebody on stretcher, if this family are paying sometime 1,000 dirham, I don't know. Some family pay, some family don't, but it depends on the insurance. So it's really painful to the family. So something we should think about it. The other thing is that when we say stage 6 is where the behavioral issues. So the behavioral issues, patient have problem coming to the clinic. These patients should be on telehealth, more home care, because they cannot use hitting everyone. So we should have a behavioral, and that's what they started the behavioral clinic. And the educational part, absolutely, we have implemented TIPA Snow, and I have, she couldn't come to the conference. We have something called Dementia Coaching Clinic, and it's handled by psychologist Dr. Arena. I have to give her a great thanks. She's certified by TIPA Snow. I've utilized TIPA Snow in US, and guess what? I have less calls for refilling Cirquel, Risperidone, and all those things. And they call me, can we deprescribe? I say, see, I told you. So patient will ask me to be deprescribed. The same patient who's asking for 4 medication. So I know I spend more time with her at the beginning, but it pays off. So a lot of people say, oh, let's press the button and refill. She's here for refill. And you know the black box scoring. But again, but having a coach will help. Having psychiatry, we were in our, so this is something, and it's about caregiver management. This is really important. A lot of medication can be removed because they don't speak the dementia language. So I have a course called Dementia Language where we teach them how to address patient. We use something we call DICE tool. So we'll talk about it. It should be in itself a talk, you know.
Yeah, in Qatar we have home health. We have a great home health where they're gonna go
With
and
mental
visit.
illness,
Yeah, any patient they're gonna visit him at home. But you know, usually
for physical illness, but are they able to handle and dissect like mental illness? This is the problem we need. Those first-hand approach staff. I'm not sure whether we are doing well in that.
it's gonna be at general medicine level. But I mean, patient who cannot come, probably he has
For behavioral problem.
yeah, probably he can have advanced dementia, at that stage, not
Right.
early. So, I'll let my colleagues in geriatric, to participate.
I know you have hired more geriatricians, so that's good. Hiring more. So now we're trying to find not problem, solution to the problem. Having more geriatrician or also mid-level trained in at least dissecting the problem and relate to the physician. They are our lenses. So that's it. And then we've talked about the care setting. Now, how about MCI? How much now having more psychiatrists help in early diagnosis of MCI? Do you think we're still missing MCI a lot?
Well, the gap in knowledge has been the case globally, and although we're trying to address the stigma and trying to educate our colleagues from different disciplines, the gap of knowledge continues. So although we're having an influx of patients, and honestly, we might have set ourselves up for failure because we didn't think ahead, as Dr. Muhammad mentioned. There's definitely a gap. We need more hands on deck, which we need more geriatric internists, more geriatric psychiatrists, and more cognitive neurologists in such field. And we need to have that panel. One thing that's definitely missing is the role of allied health. One take-home message I'm taking from my colleagues is how, yourself included, is how allied health has helped in dementia care, and this is the model also globally. I feel that I've deviated from your question. What was your question?
You forgot the question, yeah?
How much are, at having more psychiatrists, but you're a psychiatrist. So I'm barking probably wrong too because they're already very psychiatrists. When they come to you, they are cherry picked. So the same thing. So I think all of you also having memory when and not having memory problem, refer for memory reasons. Refer for memory reasons like me. So they don't come to me, they're fine. I want to check. So I suggest this thing should be taken, my experience, to the regulatory level. It is actually in the U.S. It's a lawsuit if you miss a breast cancer in a woman, and that's why it's best practice for internists. It's KPI. You check his breast, his her breast, or PSA check, or all those things.
Absolutely.
And we have reminder on EMR, leveraging EMR. It will be pop. Okay, his birthday now. He's now 50. Time to do screening. Or his diabetes. He's having diabetes. Let's high risk. So we have a risk calculator built in EMR, whichever, and regulatory level put it as a rule, like you shouldn't. And actually, Saha did excellent job. I mean, all my patients when they come to me, I always double check. I know they're coming for brain, but we also, part of our screening is make sure they don't have chemo brain or metastasis to the brain causing their symptoms, right? Or part of dementia is having maybe met in the brain. So we ask about breast cancer. So I'm 99.9 of my women are screened, and prostate less likely because I think we're doing less. So these things. So what we do suggest something like that to have it at regulatory level, like breast cancer. And I said in that first talk, we did very well, and it kills women dementia more than breast cancer. So why we have a mammogram and we don't have a mammobrain? I said it now, or I called it cognoscopy. So we are forcing someone to do cognoscopy. It's easier than having colonoscopy and cheaper. So, any suggestion, any support for that?
I just want to mention that this was actually implemented by one of our geriatric psychiatrists for a short period of time. Dr. Sharif, I'm not sure he's here, and he used the GP cog, which was validated in Arabic, and it's a very quick tool used by an informant, takes few minutes, can be administered by a Light Health or
Sure.
yeah.
So we have very individual effort to do perfection, but we need to put all those effort in like a platform. And this platform are leaders for change that communicate to health policymaker through Saha and the same thing, bodies and like Alzheimer, neurology society. We advocate for that. That we advocate for cognoscopy at certain age. We call it that way. So the OGI will run out of business. And any suggestion from your end?
Yeah, I think your point is well taken and valid. It has to come from up down, not always from down up, but it's our role to advocate. I think the part of the problem is ageism. We think of dementia as a problem of elderly, frail people. I hear this all the time. Are you going to give these toxic medications to someone who's in his 80? I'm like, can you believe that I have patients in my clinic who are in their 50s and have dementia? These people should be in the workforce, not in my clinic. So if you talk their language, saying that it affects the economy, it affects the economy. Those people should be out there producing, giving back to the community rather than here having dementia. If we address the fact that 46, almost half of dementia cases are preventable, this may change the perspective of dementia. And I think this is our role here, to advocate for our people.
Sure, advocate and just get rules and regulation. Do you have like that in Qatar, like a regulation that having cognoscopy for those patients at certain age, 65 or 50, or whatever cutoff age? I recommend lower cutoff age because of prevalence of diabetes. I'm seeing a lot, and obesity is very prevalent in UAE. So when you have obesity that duplicates, so we shouldn't be like following the same as Canada or US. I can tell you I have a lot of MCI in their 50s.
Yeah.
Yeah.
I agree.
You agree on a cutoff age?
Yeah, we need more tools.
We can.
In the US, like in my practice before I left, we used to have like a small iPad fixed where patient can run. I mean, you have a question, MCI, etc.
Yeah,
memory
something like
clip.
ADA.
Yeah, but in Qatar, I mean, usually I use the neuro psychologist. The problem, we don't have enough neuropsychologists.
Which is very costly. Our neuropsychologist, she sees 4 patients a day. She spent 2.5 hours. I think this is a loss of waste of resources and money. So to me, I refer to her maybe once every 3 months, honestly. And I refer to her that there are patients that are very tricky. They're not MCI, but they're not SMC. and they want to retire like that. So thank you. So we will go to the audience for any questions. So we talk about now the challenges, the solution, and also the practice of once we diagnose. In my practice, I would say a lot of patients are MCI. I see they have also psych problems or attention deficit in social media. I tell you, I have now attention deficit clinic, and they are convinced that they have cognitive problem. So those are my MCI. They're young folks and they're 40s and
I want to add one thing. Usually, I like to
they
watch.
have, and I cannot discharge them. They're addicted to the clinic, and I'd love to see them, but I would rather see somebody with memory. Do you have something like that? Did you run into a problem like that?
I think it's very important to screen patient because I watch other physicians when they treat patient. So whenever a patient come with MCI, he end leaving the clinic with antidepressant.
Yeah.
So physician has the impression patient with dementia doesn't complain. So if he complain, that means he's depressed or anxious, which is wrong. Now, if you have a screening tools, then you can prove that this is what he has.
Sure. So now here comes proper care, proper place, proper person who's doing that. So also we need to clarify there's big mix between among community people and among medical community between cognitive illness and mental illness. They're not the same. I am just a cognitive. I deal with cognitive, not with mental. I do see bipolar if they get dementia, and they are co-managed with the psychiatrist. But if they develop late onset mania, I can manage because that's more neurodegeneration or sometimes. It's very rare to see like mania or depression in, if they have no pre-existing. So we need also to specify. I write it in a rule, so but I still get those things. The other thing is the new treatment now for the anti-amyloid for those MCI. How much of those MCI that you have are candidate for the anti-amyloid?
I don't have numbers,
No, not necessarily. I would say percentage. You mean, like for me, like among them, few. And they are tau. Do you use tau to stratify them? Because there's still, unless you have a tau.
We started.
Blood tau.
We just started to do it, and we send it out.
I will have data. I'll share my practice next conference.
One thing I noticed is our population here is very vascular, if that's the term. So I'll find many with the small vessel disease and lacunar infarcts, and that unfortunately puts them at higher risk of any side effects. And but that also opens the door to other interventions like lifestyle interventions. I think lifestyle interventions in our population are going to have an immense impact.
Absolutely, I concur with him. I have Fazika 2, 3, and even 4. Most of my patients, due to diabetes and sleep apnea, give you white matter disease, and we have a lot of B12 undiagnosed because of the pandemic of Roux-en-Y surgery for obesity. So if they have removed the obesity, they forget to take B12 forever and give them also posterior cord symptoms. They come with numbness, and I figure out they have B12 forever and they haven't, So these things, I've seen a lot of those. Doctora?
I'll probably talk more about that in my talk when I speak about that. But we can delay that to then.
Yeah, because we want to leverage something else that
Sure.
that you are going to speak.
Okay, yeah.
So what do you?
The only thing that I wanted to say is I work in a tertiary setting where people do not have free access to the clinic, so I might be having a different population of patients, but I see the opposite. I have a lot of MCIs who have no vascular risk factors, who have clean MRIs and no vascular changes on there. So I see a different population segment, I may say, in my clinic specifically. So I have different, but the other challenge to me when it comes to the medications is a lot of them are younger than those in the trial, so in their 50s or like late 50s.
Exactly. So those group of MCI occupy most of an MCI, the vascular run and sleep apnea, and attention deficit due to This is the modern, modernist, what do you call it, modern sensory disease, and they don't need me. They need a psychologist and mental illness. I can't speak up number. And the rest are maybe very few that really starting having amyloid. So we should have lifestyle interventions. So we do a lot of stuff treating sleep apnea, and they are reversed, which is great news. So I got somebody from Kuwait. She say you treat dementia and they recover. I say it was started earlier, so I start getting dementia from Kuwait. I don't have, unfortunately, anybody from. I said not because I do miracle. It was reversible, and that's what we look for, and we're happy to do so. Now, so talk about now therapeutic. What kind of treatment is more common? So basically, more sleep-based lifestyle and mental illness. Anybody want to add? Other than amyloid MCI or amnestic MCI, so mostly vascular MCI or mixed, and even the people who have amyloid, they have mixed. So I don't have statistic, but I expect if you do the census, it's mixed. My census, even the amyloid positive ATN, I have ATNs grading for all my patients. 2 years since I start, all of them ATN, and all of them flagged by tau. So I used tau before, like since I start. So, and all of them, and I have a cutoff level for vascular and mixed. And I have also level for amyloid mixed vascular, they're higher. But now Dr. Hans working with me, they have non-binary. So the old tau from LabCorp was yes or no, binary. Either you are amyloid positive or negative. The one we're having through ALSPATH is binary and they're intermediate, which really help because a lot of patients, so be careful, that's why I want to notify the audience if you're using it. So amyloid positive doesn't mean little positive, you might have vascular disease, so it's important to, so that's why this comes to my next question. Some people suggest giving p-tau to primary care because they have no time. Let them screen with p-tau, not the cognition test. I am for cognition test, not using that with non-specialists. So what do you think of that, Dr. Zubairi?
I'm gonna be honest, I'm a bit biased when it comes to that. I don't know why though. My take from the evidence is that plasma tau tells you that the brain is burdened, but it doesn't pinpoint a specific neurodegenerative disease. It also tells you that maybe lifestyle interventions would help. However, the newest guideline also supports this by the Alzheimer's Association, and it puts plasma tau as level X, which means it requires further validation and should only be used by specialists in the field. So either trained geriatricians or trained cognitive neurologists. That's what the advice from the Alzheimer's Association is. So I would rather not have p-tau with general medicine or family physician, because also that will bring in an unnecessary influx.
Dilemma and maybe also, especially also elderly, the study of centenarian. Even now, I'm going to have amyloid testing, amyloid scan in Cleveland Clinic. And elderly, if you scan them, and if they're walking in the mall, they're smart, they're driving a car, they might have amyloid in their brain. And you really need an AI to distinguish between senile amyloid, and that will tell them, oh, go for, I need Leqembi. They don't have cognition. Of course, if you screen them, they might have little bit slowed, word flow or any one domain of those things. So this is why you need to have a cognitive test and functional assessment. Function, they are dropped from from the baseline. So we all agree that it shouldn't be done, but we know that the commercial world is coming here to the MENA region. They're like a tornado, and people will come to the physician and tell them, I think we cannot stop that, and I'm expecting a tsunami of cognitive screening, and they will jump right away to the very expensive 20,000 dirham for amyloid or FDG pad, and that's very costly for the government. I think I'm expecting that if we don't regulate that, this is what I expect. What do you think? Now with my amyloid testing of the brain on.
Okay. So I have several concerns here. First of all, I hope we don't turn cognitive neurology into Alzheimer's neurology, because because it's not all about Alzheimer's disease. That's
Absolutely.
one thing we should keep our eyes open and our peripheral vision vigilant to everything else. So we're not Alzheimer's specialists, we're cognitive specialists. That's something we need to remind ourselves with every day. The other thing is, I think until we have something. Now, when we say screening, screening means no symptoms, but we're looking for a problem. That's what screening is. And if we're going to screen people with PT217 when they have no symptoms, we should be able to be offering them something. And until we are able to offer them something different, we should not be doing this.
Absolutely.
Now, if you find someone positive for PT217, but they are asymptomatic or their symptoms are, let me say, not significant, what are you going to do next? And if they come up with the next question, when am I going to have symptoms? And again, you don't have an answer for that. I think I would be very careful with mask. I'm totally against mass screening at this point until we have something to offer people beyond exercise and.
Thank you. So we will relay your messages all as expert at the end of the conference, that these are expert opinion, that we shouldn't get. And this way, they should have it done by specialists who done all the battery, checking the motor system. There's no DLB. I have a couple of vascular and they are positive ones. And the patient insists they want to have a tau. And I told him I'm not going to do that because I'm not going to give you, for this. And actually, he was admitted with acute status dystonicus after giving risperidone because somebody told him you have Alzheimer and checked it. So he diagnosed him as Alzheimer with tremor. He or she, doesn't matter, just diagnosed as Alzheimer just because he has memory, but he has tremor when he was on Cinemed. So, and I'm very excited that we talk about the co-pathology. So that also, you need a specialist to know when. So we talk about what and then now when to do that. And I think we should not have it available, in general, like a checkup screening. Any
Yeah, I agree with my colleagues. I mean, anybody can do the physical exam and screen for dementia, but for the markers, it should be done by the neurologist because they're not going to know what to do with the results sometimes.
Could be neurologist or trained or a geriatrician or anybody like cognitive neurology because there are a few of them. So we say like anybody trained or he's working in a specialist in dementia care. I think we need to ask the audience. If somebody can organize a question, we have. Are you willing to continue for further 10 minutes, or you want to have lunch? Please, whoever wants to stay for another 5 minutes or 10 minutes, raise your arm. Oh, we have a lot. So, okay, thank you. So let's start taking questions. If somebody can rotate the mic, that would be helpful. Can volunteer too. Yeah. I can do that, but it's better to have some. Yeah, okay. Perfect.
Yeah, thank you very much for this panel discussion. I'm Abdurrahim Haj. I'm a professor of biostatistics and epidemiology here at Khalifa University. I used to work on Alzheimer's disease a lot back in Oxford University. Now I'm working on cardiovascular disease and diabetes. So when I saw this conference, I was so happy to come and just to listen. What I want as well to hear here is research-wise. What are, in some way, first, maybe it has been done yesterday. I was not here for some reason, but I want to know about, for example, the prevalence of Alzheimer's disease here in the UAE, the region, the incidence, and as well if there are any cohort studies or clinical trials about MCI as well, if there any research that has been done, or because I think there is a huge need for studies like that, especially about preventing Alzheimer's disease and looking at the progression of MCI.
Thank you. I think I'll give it to someone from Saha, but number one thing, I think we need to have a registry like we do for stroke, because any data has to be first registered. And I'll lead Dr. Zubaydi answer this question.
Yeah, so at Saha, we're lucky that we're supported by Khalifa University. Dr. Saghir is in the audience here, Dr. Amna Shahi, Dr. Leontis, and many of the staff. there is a focus currently on cognitive disorders at Khalifa University, and through the Mental Health Council, we are trying at Sakina to help and to provide them access to the population. Our focus, however, is early detection. That's one thing. And in terms of a registry, there is also talks with the Department of Health. Dr. Sharouch is on top of that. He presented yesterday, and so he's the man on the job, and he usually gets jobs
That's
done.
why I invited him.
Yeah.
Yes, I know it starts from the government as well to have that. That's wonderful. So we do, and we are very happy to. We have started also having neurology residency program. So, but again, we need to have a registry and multi-center. We have some IRB on biomarkers. I'll be happy if someone from Khalifa. We're doing something with. I think a lot of them, a lot of you guys are very keen on doing something with us, and we are also very keen from Saha, from Cleveland. But again, we need to build a structure. It goes beyond our talk. For me, I can share my cohort for two. I'm happy to share with you. We have also biomarkers data, which also validates. We have also neurocognitive score on all of them. So, and they are perfect for just retrospective. Let's start retrospective of what we have and do prospective. So I think this is a way to go from my end, at least in my practice.
And actually, yesterday there was somebody presented the numbers in the Gulf, somebody from Saudi Arabia, about the incidence and the prevalence. So there's already studies about the disease in the area, but of course more need to be done.
But that was, yeah, again, but was there any cognitive score? This is a question. So labeled as dementia, we know Alzheimer at that time was anybody who have memory, as she said, Alzheimer. It was really, it was misnomer. No one, thought about vascular and mixin, which is very common. So we need to know, is it Alzheimer or dementia we are talking about, which is a big umbrella, right? So, but that's something, that's what we need also, biomarker data, I think now. Wonderful question. Any question?
Thank you very much for this nice discussion. As it was understandable that relatives of young patients with Alzheimer's disease are very concerned. Do we need to screen the relatives of these young patients with Alzheimer's disease or MCI? And if we do need, which tools we use, and is there a cut edge to screen these relatives?
I have a answer for that, but I'm gonna let anybody. Interestingly, so in my practice in here, most of my patients are daughters of my patients. So I see the daughter, son, and family because they've seen their father and loved ones, and they want it to be checked. So it depends. Yes, I do. I screen them based on symptoms and absence of symptoms. And I found out one of them really having MCI. So I usually, it depends. So what with cognitive tool, it's very tricky question. It needs like half an hour that, but what I can tell you based on education, if the daughter is having like a 12th grade and above, I can use MOCA or SLUMS. SLUMS is a standard KPI. Anybody comes to my clinic, he should have a SLUMS. And and then I go MOCA. The reason I do slums is MOCA is very hard to screen because patients not all of them are educated. So, and then I do the other MMSE, and I do a lot of them are MOCA and slums. And we have also an opportunity to go retrospect on my data. I still need to validate which one work. This is an easy project for any of you. Just go back on my data. I have significant number and see which one work. And I have some of them having MMSE. So let's understand the landscape of what the humble 1 year and a half I've been here in US and UAE 2 years, for instance, or if also Saha has record, and we can do prospective. But again, there's no single tool that is good for anyone. It depends on the vocal skill, education level, ethnicity. But slums was working, but not all the time. I hope I answered. Okay. So we're almost done with the debate, unfortunately, because of the lunch. We can do that at the end. I wanted to thank our expert panel. We should come up with summary. So so not yet. How much? When is the lunch? That's great because yeah. Okay. So we're introduced. Okay.
We all need to be screened.
Okay. All right. We can write down our recommendations. At 12, we have now early onset dementia, right? Presentation? Oh, Dr. Riyad, okay, okay, can see that. Oh, so now we'll have an open session with Dr. Sahil. I'm sorry, I can't read this. Sorry. That's funny. Right. I just group it. The light is coming off here now. That was nice enough.
Shall we start the next session? Okay, thank you, Hanan. Thank you, everyone. Thanks for the panel. Our next session is regional need and challenges. I would like to welcome my co-chair, Dr. Mohammed Hattu. Mohammed is a consultant neurologist from Doha, Hamad Hospital. And our first speaker is Professor Raad Qwaider. Professor Qwaider is from Tunisia. Always when I will read his CV, I will find something new with Professor Qwaider. So Professor Qwaider is the head of Department of Neurology at since 2020 and Alzheimer Center Chair since 2010 and multiple sclerosis at Raz University. He has been active in many international societies, including World Federation of Neurology, and next month he's running the Pan-Arab Congress in Tunisia, so everyone is welcome to visit them in Tunisia and Hammamat. And today he's going to speak about the early onset of the dementia. Professor Qwaider.
Thank you, my brother and friend, Dr. Suhail Rukn. We did together here in the Emirates the 2019 World Congress of Neurology, and I think that it's still an unforgettable event. I was asked by the committee to make a presentation on the regional needs, so I will speak about what we have in our experience. I see that it's already 16 minutes, 20-minute talk or 16-minute talk? Okay. I have no disclosure with this. Why I'm speaking about this, why I'm interested. Because if you see the problem of dementia in the next 25 years, it will be the low and low middle income country and the Middle East and Southeast Asia. So what does it mean? It means that all the Occidental world have now controlled their epidemiology. We are on the rise. And look at the numbers. If you see the low and low middle income country, which are the majority of the country of the Middle East and North Africa region, the proportional increase is 246% in 2050, which means that there's a tsunami on this coming to our countries, and I'm not sure we are prepared to this. This is another slide to show the increase in our region. It's about Africa and Middle East that are put together. And if you see the prevalence of dementia in North Africa and Middle East, it's now nearly 3.6. It will go to 10.10. It will be 3 times what we have now if we don't do anything for this. The early onset dementia is part that I will speak about. It's specific. We are sharing dementia with the geriatricians, but early onset dementia is a neurological problem. And it has to be led like this because it gives a huge problem to neurology. It's an old story. It was even from Darwin, but I think that it has been cited even before. But what we have to say about is that the first case of the dementia was the presenile dementia. We don't speak now about presenile dementia, but that's the Alois Alzheimer case 120 years ago. Early onset before 65, young onset before 45. And you will see that it's a huge problem that is often misdiagnosed, and the specific and timely diagnosis is crucial. This is, for example, figure that shows that for our region, few things are known except for Egypt, but one of the problems is that the studies who are in other languages, like French, for example, and Arabic, are not accounted on these figures. So this is to say you that it's a problem with a lot of papers, and the prevalence is now becoming an urgent subject of research. Here, when you see this slide, you see that the prevalence, as I said, is increasing, and you have 54 per 100,000 inhabitants that can be affected by this. So 0.4 per 100. And when you see the study in Norway, it's saying that between 45 and 64, you have 143%, which is 1% roughly if we divided the numbers. And it's coming to double with each 5 years increase in age. I will go to the experience. What about early onset dementia in Tunisia? The prevalence of dementia is now nearly 5%. And at this moment, I want to just share an experience with you. Perhaps in the Middle East region, the problem of financing is not there, but in several countries in Northern Africa, in Sham, Iraq, etc., this is a problem. And when I have seen our Minister of Health in 2004 saying that Alzheimer is becoming a problem because Tunisia is the most aged population in Africa and Middle East. We are the only country that the mid-age is above 30. And he received me, the interview duration was 30 seconds, and he said me too expensive, bye-bye. I have been to the civilian society, and fortunately there was a foundation who was able to sponsor the first Alzheimer center. It opened in 2010 in the Middle East and North Africa. That was the first one. At this moment, Alzheimer's disease was not considered as a health problem, while now it's considered as a real health problem. And this center allowed us to have the series I will present. One of the first question that you will ask yourself is what we are doing something that is trustable? So we are becoming from French tradition, neurology, Charcot and Alain and all these people who worked a lot on neurology, and the cognition is a very important part of the French neurological tradition. So everyone has the family history, but everyone has also the imaging, the biology, the EEG, if possible the CSF, and we have a lot of problem of CSF because it's not accepted in our region. A lot of patients don't accept to do CSF, and that's not the patient himself which is dement, but the family says to you, we don't want CSF unless there's a very urgent matter. We have developed our own testing that were validated in our population. The MMSC has been validated in Morocco, in Tunisia, with the dialects, and this is a test that we developed, which is the 100 battery that is reliable to our population. So there's no problem on the diagnosis. And I will speak about the cohort we identified. We have in the center nearly 9,000 patients that have been screened in our center. Among these patients, you have 1,484 patients who are early onset. It gives a percentage of 17%. It's by far more what is described in the Occidental population. Why the number are so high? we can discuss it a lot, and it can be a matter of debate. One of them is the center effect. If you have a center, and if it is the only center, the difficult case, the early case will come to you. But it's not the only explanation. If you see the series, there's roughly as many males as many females, which is the difference with Alzheimer's in the late onset. And the mean age at first consultation is 60 years, but the mean time to diagnosis is more than 3 years. And this is a huge problem. Symptoms are memory complex, the majority, behavioral complex in the half of cases. And we have to find out early onset dementia etiologies. If you see this evolution, unfortunately, what we have to see is the two last figures, which is more than 45 and more than 65. And you see that if there is no neurodegenerative etiology before 40, it's very rare. After 40, it's becoming important, and neurodegenerative etiology is the most important after 45 years. So after 45 years, Alzheimer's disease becomes predominant among dementia. And this is what we see in this graphic from Rossor and colleagues, and we compare this to what we found, and you see our center compared to the recent monocentric studies of MS. Unfortunately, the numbers are not equal. We are comparing 1,200 in us and 250 because the problem is not managed on a monocentric way in the other studies. What you can see is if you see Alzheimer's disease, it's already the half of our patients for early onset dementia. And the number also are similar in the other studies. We have gone to genetics to understand what's going on for the etiology. Is early onset dementia more likely to be familial? That's the question we asked ourselves. And you see that if you have early onset dementia, 1 patient to 3 have familial history. And if you go to Alzheimer's disease family, 2 patients to 5 have familial history. The question was speaking about what we should do. We are not doing testing in the family because we cannot provide now any treatment, and it's difficult to announce to a young person that he's at risk for Alzheimer's disease when you have no treatment. And this will come with the plasma that we will go on the foreign countries, and people will come to you saying, I have a positive test at the age of 45 and 50. Why? It's an Alzheimer's disease. It's not yet an Alzheimer's dementia. And we should think together on this problem before it becomes something that we can't control. When you see the conclusion of this study, which is on clinical feature of Alzheimer's dementia in Tunisia, late onset dementia, you have more dominant pattern. But when you have autosomal recessive pattern, it goes more to early onset. What does it mean? We are people that have a huge inbreeding. In Tunisia, it's 29%. In Saudi Arabia, it's up to my knowledge nearly 40%, and in Sudan, it's 44 or 45%, which means that our populations are heavily inbreeded, and that this may be one of the clues on our research. Recessive traits are more common in the Tunisian population with high level of consanguinity, as I say, and the likelihood of inheriting 2 copies of harmful recessive alleles is there. This is one of population in early onset dementia that were linked to a novel presenilin 1 and that we have published years ago on this mutation. And Bob spoke about dental health, which is very important. We did our work, and what we have seen is that the dental health and the bacterial health is linked to Alzheimer and to a more earlier beginning. And we have to know that the people who have now Alzheimer or MCI, I will speak about MCI later, are people who were from a generation where the dental health was not very, very followed. So I think that we will face a problem on this situation, and we published this paper, I think, 2 years ago. There are positive results, but there's also negative results. TREM2 variants who are known to be one of the risk factors are not in our population a risk factor. What the clue of the message is that we have specific genetic patterns. I don't think that the global patterns that are in other countries are the ones who are fitting to our population. There are whole exome sequencing that is done in the world. I will, for sake of time, go through this because it has been extensively spoken about. But there are some that are specifically associated with early onset subgroup of these genes. Early onset versus late onset. You see that there is a lot of comparison that is there. And the consequences are one of the most important things that we are facing is the delay in diagnosis. Why in late onset, the diagnosis is by 1 and 1 year half earlier than late onset. And this is very important because these people will be mismanaged for a very long period. There's also the burden and cost. Early onset dementia is for people that are still economically active, that parents of young child, that are usually the main earner in the family, an unemployable age, socially productive. And you come to a person with this such profile and you know that he will be needing the help of his caregivers. The direct costs are very important, but the indirect costs are even more important. And to my knowledge, there is no study in the region taking care exactly of the early onset cost, which is very high in the family that we are in the United States. It's approximately $47,000 per person per year. And don't forget that on early onset dementia, you still have to target potentially treated etiology like tumors, like hematomas, like vitamin B12 deficiencies, etc. And if you have to want more about the global burden, the risk factor, and the projection of early onset dementia, I advise you this paper who has been published on 2021, who take the whole figure. There's a rising widespread concern about the escalating EUD burden among the global middle-aged population. We have all the risk factors that are coming. We all have been explained: diabetes, hypertension. We have higher number of hemorrhagic stroke. We have lower age of ischemic stroke. Correct me, Suhail, if I'm wrong. And the risk factors are there. The risk factors are important. The people under 30 to 50 years in our population don't think about their health at all. They are productive, they work, they think to build their house, to make the school of their children, and they don't think again. The majority is not doing exercise, is not controlling the tension, is not. That has been solved more better in developing countries. And I think that if we let this risk factor working like this, we will not be able to face the consequences in our population. The consequences, this is an old publication. What it says? It says that if you delay the onset of Alzheimer, you make a huge difference of the cost of the disease. But what if we delay the beginning of early onset dementia? Our discussion with the stakeholders is to say, if you let it, you will pay a huge price. Usually they don't think about it because the price will be paid by their successors. But we have on a health point to say to them that early onset dementia in our region will be a huge problem in the next future. In conclusion, early onset dementia is more frequent than we think. It has broad variety of etiology, but when we are on more than 45, it's Alzheimer. the management is more challenging than older patients. We have to know that the sufferance of the caregivers we did the study is more important when it is early onset than when it is late onset. And I will make it frankly, the men in our team don't accept the dementia of their spouse because they are facing to take care of the children, to take care of the family, to take care of the house, while they are not prepared to this. And it's becoming a medical and a very important social problem. Now the biology is coming on a very fast track, but please put it in its context to avoid to have the medical burden, the social burden, and the psychological burden. Thank you so much.
Thank you, Dr. Riyad, for this, beautiful presentation. I want to welcome our next speaker, Dr. Miss Aya Jamali. Miss Aya is a dedicated occupational therapist for more than 15 years. She grew up in Canada and she got her master's degrees from Wayne State University, Detroit, Michigan. She's been working in the Cleveland Clinic as an occupational therapist for more than 8 years. She's been taking care of patients with neurological problem as well as basic hand function. She holds license in many countries, including the U.S., Canada, and probably here in Emirates. Her experience as well as her compassionate approach helped her to reach meaningful improvement for her patient. So thank you. Bye.
Hello, good afternoon. Thank you so much, Dr. Hanan, for your invitation to be here today. It's been an honor working with her every day in our memory clinic, and we look forward to many more days together, hopefully. Okay, so I know we've seen different versions of this map every day, and as everybody can see, the rise just continues on and on every day, so I'm not going to go on with that. Somebody earlier asked about UAE prevalence, so this is just a little depiction of where we are globally, our Middle East categories, and where the UAE stands, and probably just a little bit less because of the population in the UAE. So as of right now, we have about 57 million people worldwide that are living with dementia. So that's a huge, huge number. So the UAE is witnessing a rising in the incidence driven by, as we know, our aging population. A lot of it is lifestyle-related factors. Our sedentary behavior, diabetes, hypertension, and cardiovascular diseases. Our challenges are limited specialized care center resources available for cognitive rehab, and our limited prevention awareness and rehabilitation. Thank you. Oh, okay. So I know I'm the only one in Cleveland that does this with Dr. Hanan. We see about 12 patients a day, but I know we get referred from her clinic at least 200 a month. So that's a big limit right there too. Today's focus is going to be a little bit on neuroplasticity, and with the increasing prevalence, we know there's a critical need for innovative, cost-effective approaches to managing Alzheimer's disease and dementia. Neuroplasticity-based rehabilitation plays a significant role in these challenges by offering a non-pharmacological intervention to help maintain and enhance cognitive function in the affected individuals. So as we know, it's the brain's ability to reorganize and form new neural connections in response to learning, experience, and or injury. We have different kinds of neuroplasticity. Major one is our functional plasticity, which is the brain's ability to compensate for damaged areas by reorganizing functions. And we have our structural activity, which is physical changes in the brain structure in response to experience. How is this relevant to today's topic? Because neuroplasticity offers a potential avenue for rehabilitation, even as a disease progresses. Foundations, we have our synaptic plasticity, which is strengthening or weakening of the synapses in response to activities, learning and memory. Neurogenesis, the formation of new neurons in the brains in certain brain regions, such as the hippocampus. And our cognitive reserve, which is our brain's resilience to damage, influenced by factors, like education and mental stimulation. And I always tell my patients this every day: if they don't get anything out of my 30-minute session, it's at least some sort of mental stimulation that they would have lacked, anywhere else. Synaptic function, which is, I know somebody had mentioned this a little bit, but also Dr. Hanan and I talk a lot to our patients, just like our brain needs exercise, just like our body needs exercise, our brain also needs exercise. So I divide it to my patients as 30 minutes a day. So 30 minutes of environmental enrichment, 30 minutes of physical exercise, and I always talk to the caregivers about engaging with the patient. So when I ask the patients, what are you doing every day? Their common answer is nothing. I'm just sitting at home watching TV, which is, as we know, is a passive activity. So it's always dedicated engagement time with that patient, obligation from that family member to do. Just gonna skip. Yes, okay. So why Alzheimer's causes this damage, the brain retains some of the capacity for neuroplasticity, particularly in the early stages and the moderate stages. Targeted rehab can promote neuroplastic changes, enhancing cognitive functions. And cognitive training leverages neuroplasticity, which again is the way the brain's ability to reorganize and form these neural connections. So what is cognitive activity, and what is it that I do every day? So this refers to structured activities and exercises designed to enhance cognitive abilities like memory, attention, executive function, and problem solving, with our goal to stimulate neuroplasticity and reinforce new neural connections. Alzheimer's dementia primarily affects episodic memories, leading to severe deficits in recall and recognition. So, benefits of this cognitive training: we're enhancing memory and learning. We're compensating for brain damage. We're slowing down disease progression. And we're also strengthening neural pathways, building on our cognitive reserve and adapting to decline. So if I have a patient come in and they're in a severe stage, a lot of the family will look at me and they'll say, well, there's nothing that I can do. So at this point, it's kind of teaching our caregivers how can we make this easier for both them and for our patients at the same time. Let's take a quick look at the domains that are affected in dementia. So like we said earlier, it's mostly memory, our attention categories, and our executive function. But there's also a little bit of a hierarchy of these domains. For example, I'm just going to skip here a little bit to make this clearer. Oh, sorry. So let's say I've highlighted the problem to be an issue in executive functioning. I'm not just, I have to make sure that all these pyramids are met before. So I have to make sure that my patient is able to maintain attention. I have to make sure that my patient does have that basic perceptual skills. Their memory is intact. Recognition skills are good. Practice to make sure that I can educate my patient on executive function. How are we doing this? Sorry, it's clicking too much. We're teaching acquisition skills. We're applying these skills. So, how are we going to improve effectiveness, independence in compensating for this benefit? And we're working on adaptation. So we're promoting transfer of learning of this task that are less structured, more novel, complex, and or distraction. We are promoting generalization of skills to less structured environment, in the home, community, and the work. Because as Dr. Hanan said, and many of you earlier, we're seeing a lot of these deficits now in patients that are younger, that are still working, and that we have to make sure that we're able to adapt these challenges at that time too. Okay, so again, let's go back to our key principles. We have our brain stimulation. So cognitive training involves activities that engage specific cognitive functions, promoting neural growth and reinforcing these synaptic connections through repetition and through practice. So regular practice and repetition makes tasks help improve these cognitive performance and lead to long-term benefits. Repetition also strengthens the neural circuits involved in memory, attention, and cognitive function. We have progressive challenges, which is training programs that should increase in difficulty over time to continuously challenge the brain. And we also have increased engagement and motivation. So maintaining interest and motivation. We can't give a patient an activity that they find boring. It has to be something that they're interested in. If you have a patient who's, as we say, an old mama who loved cooking and baking back in the day. So that would be something that would engage her and motivate her more. Would talk about how we, tell me a recipe to this dish that you used to make, just kind of make it more engaging and more motivating to come, versus me giving her a puzzle, which is going to be meaningless to her. Again, it's about those functional tasks that we talk about all the time. Memory exercises, so activities like memorizing tasks, word association games, and recall exercises. Recalling a list of words after a short time. I know that's in a lot of our standardized tests. Matching objects to their corresponding images. I really like that one because it's more of a functional task. If you have a whole bunch of objects and you ask the patient to match it, it's more of a functional task than if you have different literacy, it wouldn't apply. You have your attention and focus tasks, which is exercises that are designed to improve sustained attention and the ability to focus on specific tasks without becoming distracted. So example, completing puzzle or activity that require concentration. And sometimes when a patient has excelled in this, I'll just add a little background music to that, or I'll have a side conversation with their family member at the same time to kind of challenge that attention and build on it. And we have our problem solving and executive functional training, which is tasks designed to improve reasoning, decision making, and cognitive flexibility, like strategy games, planning exercises, or decision making scenarios, which is also another very good functional assessment. And for our more tech savvy patients, which we see a lot of our younger ones now, we have our computerized cognitive training programs, digital platforms like Cognifit, which is available in both Arabic and English. There's Luminosity and there's Brain HQ, designed to kind of target multiple cognitive areas. There's a new one in Arabic, but I'm not sure about the standardization of it, called Shola. But it's not validated yet, but it's the only one that's directly Arabic at this time. Another good thing is cognitive stimulation therapy. Now, this is not something that we do a lot at Cleveland Clinic, just because a lot of the patients don't want to be combined with other patients while we're doing this cognitive training, just because of privacy issues. But it is a structured group-based intervention that improves cognitive and social function in individuals with mild to moderate dementia. It also works on enhancing memory, executive function, as well as overall well-being. And participants have showed improved communication skills and higher engagement in daily activities. Cognitive domains that are affected: memory, attention, executive function, and language. And in the next graph here, you can see the impact of this therapy, especially the memory or executive function, as well as social interaction. So the benefits to all this is things like we've said all throughout this weekend, is slowing cognitive decline. We're improving, quality of life. We're providing the support to our caregivers. reducing their stress, because I think that's a big portion of it too. Barriers that we have, especially in the UAE region, the brain's capacity diminishes with age, and severe Alzheimer's may limit the extent of rehab. So when we see our patients, they're already at a much higher level that they can't really engage in any of these therapies. Individual variability, like I said, genetics and overall health, and the need for early intervention. I know Dr. Hanan tries her best in the clinics to screen those out, especially for the early intervention, but it's also neuroplasticity is most effective when we're diagnosing early. Barriers to cognitive accessibility, we have limited digital literacy. So our older adults are not tech savvy, and whenever I show them an iPad or an iPhone, they're kind of, scared away. So they're struggling with that technology-based cognitive intervention. Something else we've talked about over and over is our financial constraints, especially if we want something specialized that may limit accessibility. And skepticism about how effective it is. They'll come to the clinic and say, Dr. Hanan made me come to you in the brain clinic, but I'm not really sure how you can help. And they'll be surprised how much we can do in those 30 minutes. So when in doubt. And we also have a lot of our cultural impacts. So we have our dementia stigma. So where cognitive decline is perceived as an inevitable part of aging, discouraging early diagnosis and intervention. We have our traditional healing practices, which a lot of cultures still believe in, herbal treatments or faith-related beliefs, or, this is what's meant to be, this is God's will. And our family-centered care. Strong family support can enhance care, but may also lead to delays in seeking professional assistance. So we'll get patients all the time where their pills are being provided, they're being bathed, they're being dressed, but these patients are able to do all that. And as much as the families want to provide and want to support, but it's the overdoing that's kind of making that brain lazy, and they're just having to rely on everybody else to decide when the pills are going to be given, decide when I pray, decide when I eat, what am I going to eat. So it's a big impact. What's our future look like? We talked about VR-based cognitive therapy, which is it's creating immersive environments that improve spatial memory and attention. Neurofeedback training, kind of monitoring real-time brainwave activity to optimize exercise, or maybe brain stimulation devices that offer an invasive method to enhance synaptic plasticity. So yeah, that's it. Thank you.
Thank you, Aya. Very nice presentation. We keep the questions till the end. Our last speaker, Dr. Roa Khalaf. I'm so glad that if I met someone during this Congress, Roa is one of the top that I met her during this Congress, and to introduce her to our community, Roa is a consultant neurologist and cognitive and behavior specialist. She's coming from Saudi Arabia, from King Fahd Specialty Hospital in Dammam. She did her training in Saudi Arabia at King Abdulaziz University and did her fellowship at Toronto University, mainly at General Bakewest. Okay, and she's currently the director of the cognitive lead in the Minister of Health, and today she's going to speak about a very interesting topic, which is the cognitive disorder in Saudi Arabia, a pathway from primary to tertiary care. Welcome, Dr. Roa.
Thank you, Dr. Sahel, and thank you everyone for sticking around until this time. I hope I can be quick, so I'm your only barrier to lunch. I'll try to be. I'll be talking about navigating cognitive disorders care in Saudi Arabia. It's more of a story. It's the story of cognitive disorders in Saudi Arabia, especially in the Eastern Province where I practice. So these are my disclosures. These are the outlines. I'll skip the current efforts and future directions because Dr. Walid talked about them yesterday. So the story started in 2019 when I came back from my fellowship. At that time, and it's still the case that there is no, well, the case currently is I'm the only cognitive and behavioral neurologist in the Eastern Province. So this is the only program in the Eastern Province, and it's the only program in the Ministry of Health on a national level. So I work in a tertiary setting. So the program is in a tertiary hospital with limited access. So patients do not freely access the hospital. We're a team of cognitive neurologists, myself, geriatric psychiatrist, psychologist, social worker, coordinator, and speech and language pathologist. And we kind of provide a comprehensive care from initial assessment to diagnostic, comprehensive diagnostic workup, establishing a treatment program and long-term monitoring for those patients. We've also developed a caregiver support program or caregiver support group programs where I was discouraged in the beginning. I was told that our community is conservative, people would not be interested or would not be willing to be vulnerable and share intimate details, but that was not the case. Actually, people were very appreciative of this initiative. We're also starting a cognitive stimulation program similar to what Ms. Aya is doing, led by a senior neuropsychologist in our center. So it's going to be starting this month, inshallah. We try to adopt technology in our practice. So a lot of the caregiver support groups that we do are run in both virtual and in-person setting. And we also are personally in the cognitive neurology virtual follow-up. So we do the consultation virtually rather than in person, which makes it easier, minimizes no-show, especially for frail elderly people in the late stages of the disease. However, we try to balance this with patients' expectations because it's not uncommon that I hear this comment, "Doctor, we have not seen you in a while. When are we going to have our next appointment?" When I just called them 2 weeks ago. Because some people do not believe in this virtual follow-up unless it's physical, unless they pay the visit and come to hospital. It's not to them, it's not a appointment. So the program started in 2019, but I would say we collected most of the patients in the last 2 years when it became more popular. We have a total of, last time I checked was 175. It's probably a little bit more now. It's not surprising that majority of our patients are female, like 2/3 of the patients are females, 1/3 male. The most common presentation is memory disorders, followed by executive dysfunction, then language, and 70% of those people have psychiatric symptoms, mostly depression. Now, when it comes to the stages, what stages of dementia do we see in the clinic in this program? And interestingly, and most of the patients are actually in the early stage. So if you go to fast staging, most of them, like 2/3, are in stages 1 to 3, which is early. To the advanced stage, so those who score on fast 5 to 7, and you do further assessment, further dissection with BADL, for example, you'll see that majority of them, like 2/3 of them, are already too advanced and too severe. So it seems like people stay in the early stage for a long time, but then, and I always use this quote from Ernest Hemingway when Mike was asked how he went bankrupt, he said, 2 ways. Gradually, then suddenly. And if you ask me how my patients decline, I would say 2 ways, gradually, then suddenly. So they stay in an early stage for a while, and then suddenly they're already too advanced. And I think there are so many confounding factors to this. We used to say people present late, but no, people really present early. But it's one of the challenges that we talked about early is that we don't really have very specific and sensitive functional assessment tools that we can use in the clinic, and that makes it so many times, even when people present early, so many times difficult to pick them when they are at that verge of conversion from MCI to mild dementia. Now, interestingly, that's another interesting observation that I had in the clinic. Most of the patients do not have significant vascular changes on their MRIs. So when I say significant vascular changes, I'm talking about Phasica 2 and 3. So maybe a little bit of Phasica 1 or non-specific white matter changes, but not significant white matter changes. But here comes again, echoing Dr. Riyad, the age at time of symptom onset. Although still the majority do present after the age of 65, but a big portion, a big bunch of them, like around 46%, present younger than the age of 65, which is quite concerning, so early onset dementia. And if you look at those who are younger than the age of 65, you will see that not all of them have significant vascular risk factors. So majority do not have diabetes, majority do not have hypertension, and do not have ischemic heart disease. And then if you look further, you will see that the majority have positive biomarkers for Alzheimer's disease. So we're not talking about functional cognitive decline, we're not talking about obstructive sleep apnea, we're talking about genuine biomarker-based Alzheimer's disease. Now, if you look at the biomarker status overall for all of the patients, whether 65 or older, majority of the patients that I tested in the clinic came back positive. So in summary, we have higher rates of young onset dementia in comparison to the world. We have higher AD prevalence in those younger than the age of 65, and vascular risk factors are not the main driver. Now, someone may say that you're cherry picking your cases, you're working in a tertiary center. That might be true, but these are the numbers I have. These are the data I have from the practice that I do. Now, I truly believe that of salt, so I'm not taking this for granted, but this is something important to look at. And I truly believe that we cannot really understand the complexity of dementia and Alzheimer's disease by just splitting it into small pieces and looking into it individually. I think we have to look at the big picture, and we need to have a bird's eye view to the problem. Now, Saudi Arabia was part of the Paris report that was recently done. It was the only, we're not an OECD country, but we were part of the Paris report. We were the only Middle East country, the only Arabic-speaking country participating in this report. And interestingly, although, yes, people do, and one of the find out of the Paris report is that I find really interesting is that although, yes, we're helping people live longer, but not necessarily better. And so quality of life for older adults is not at what we want it to be, and this is something that an action needs to be done about it, and dementia is one of the factors for this. And again, one of the findings of the Paris report is that we don't really need to spend more money to improve healthcare. Money is finite at one day. We are running out of resources, and we need to be creative and innovative in finding solutions to the problem. So more money is not always the solution. So I'll skip this slide. And so going back to the clinic, to the story of the clinic, putting all of these pieces together, burden of the problem, money is not always the solution. I decided that I was sitting there in the clinic and just pulling people out of the river, and I thought that maybe I need to do something more. I need to get up the stream and see why they're falling in the first place. And this is where the idea of having a pathway came. So as I mentioned earlier, I'm privileged to be working in a Ministry of Health setting. So I'm privileged to work in a setting where there are primary, secondary, and tertiary care, where it's easy to connect the dots and connect the pathway. And if you look at the current patient journey, when it comes to dementia, it's just like everywhere else. It's very scattered, and so many times people end up being nowhere. They don't know where to go and to whom. So we proposed a solution or a model in which this is how we look as a group at dementia care. The proposed model is to have brain health clinics where we tackle both prevention and early detection, and then memory assessment clinics where we do further testing, and then cognitive disorder center of excellence where the tertiary care is done, where amyloid targeting treatments can be given, where future treatments can be given, and clinical trials can be done. So we created this team of experts from different disciplines. We did a gap assessment, and we set two or few main aims and objectives. Prevention was a very important prevention and raising awareness was a very important aim and objective, and also early detection and streamlining of cases and providing equitable access with unwarranted patient population. We decided to move from that perspective of thinking of dementia as a specialty segmentation. Psychiatry treats that and geriatrics treat this. And we move towards a 3D healthcare, adopting a value-based healthcare system in which we segment population based on their problem rather than on what specialty to treat them. And we chose, so this is what we did. We chose Bristol Activities of Daily Living, as I mentioned earlier, because it's validated in the Saudi population and we have the permission to use it. So we are using it to segment people. So 0 is normal, 0 to 20 with abnormal assessment is MCI or mild dementia, 20 to 40 is moderate, 40 to 60 is severe. And this is the rationale of why choosing this. So this was the study done by Dr. Walid Al-Kreidi, who was here yesterday. And for the, as I mentioned also earlier, for the cognitive assessment tools, we've decided to use MOCA for those who are received more than 5 years of education, and RUDAS for those who received less than 5 years of education, based on what's available in terms of normatives and validation. So this is the RUDAS validation in Oman, and this is the MOCA normative study in Riyadh. And then we use these cognitive assessment tools after the stratification. And based on that, we send patients either to the experts for further assessment and for appropriate diagnosis, to the memory assessment clinic in a secondary setting for like management of dementia, or to home health care for those who are quite advanced. And this is basically the pathway. The most important part of the pathway is we're not only there, and it's very important for this pathway to sustain, is that its goal is not to provide anti-amyloid treatment. This is not, because if tomorrow we discover that these treatments are not, or if the government decides that these treatments are not worth it, then this pathway would be not worth it as well. So this pathway, the main aim is really to prevent dementia. When the Lancet says that 46 of dementia patients are preventable, then we are obliged to do something about it. So some reflections from this story, some reflections that I have. So the first reflection is probably a summary of what we've been saying for the last 2 days, is that family is an important dimension when it comes to decision making. It's very common in the practice to have the whole family in your clinic coming asking about what's the diagnosis, what's the prognosis, what's going to happen next. This is for example, these are very common scenarios that I have: a 61-year-old female newly diagnosed with Alzheimer's disease, and the daughter who was there at the time of disclosing the diagnosis is requesting another appointment to discuss the diagnosis with the whole family. So family is a major player in the story of the Alzheimer's or the dementia patients, and it needs to be taken into consideration. Even sometimes when a power of attorney is assigned, it either happens late or it never happens, or sometimes even when there is a power of attorney, that power of attorney insists of having the whole family at the time of discussion. Another reflection is that diagnosis is not always relevant to families. So I had this 58-year-old female who was presenting with atypical presentation of language problems, and her MRI was showing left temporal atrophy, and FDG was showing left temporal parietal atrophy, hypometabolism, and I offered CSF analysis. But the family were like, why? Especially that this was like 3 years ago. And I said, well, to find out the diagnosis. And they said, and then? I said, well, you will know the diagnosis. And they said, who cares? We don't want to know the diagnosis if you're not going to offer anything more than that. So that's another thing that's culturally prevalent, and we need to take into consideration that people do not always care about the diagnosis. Caregivers are usually the family members. They're mostly females, could be employed. So this puts another burden on the family and caregivers. Sometimes we may have multiple caregivers. It's very common that every time I call in the virtual assessments, the person who answers or who takes the call is different than the one before, and I have to go through everything again, describing everything that we've been doing, re-educating them. Paid caregivers is a thing. So we do have people, although long-term, like moving people to long-term facility is not very common, but having a long-term caregiver, paid caregiver at home is common. It happens, and education of those paid caregivers is very important. End-of-life care. Dr. Hamad yesterday was talking about the PEG tube, and I know for us who were trained in the West, whether US, Canada, or UK, we look at this as you're just prolonging misery, or as Nietzsche says, you're just just delaying the death of this person unnecessarily. But reality is we should accept that this is the culture. Sometimes you're not really treating the patient, you're treating the family. And you have to take this into consideration to alleviate the feel of guilt that they may have towards their beloved one. So I have this scenario very common, very often. So this is a 57-year-old female with advanced young onset dementia who declined significantly over the last year with decreased oral intake. Their family kept taking her from one emergency room to the other because she's refusing to eat. They are unable to give her the medications, and we ended up doing the PEG tube for them. We ended up doing the gastrostomy to treat them, not to treat her, and that's fine. That's okay. There's no shame in doing this, and we should not be ashamed of doing this. That's another patient, a 59-year-old, that I just called her brother a couple of weeks ago, and he was like, what happens if she gets worse? What happens if she's unable to swallow? We're giving her puree diet now, and I'm anticipating that a couple of weeks from now, she might not be able to swallow. And I was like, that's fine. Maybe you should not force her to swallow. But then he struck me with the answer, so we just leave her starve to death? And we have to understand this. We have to understand these emotions that these people have, and we should have our own end-of-life care programs. Another reflection is that we feel as physicians. I always remember this 2017 when we were doing rounds in 4 West, and we entered into a room of a patient who was he was relatively young, and he was sitting on a wheelchair, tied to the wheelchair, hallucinating, delusional, imagining things. And I was just thinking of him, of his family, of the person he used to be, and I just cried. I cried my eyes out during rounds in front of everyone. It was traumatizing to the team, but it was really how I felt. And guess what? 7 or 8 years later, now I still cry. I still feel a crack in my heart every time I tell someone they have Alzheimer's disease. And I try to remedy those cracks by reminding myself of why I'm doing this so I can put up with all the hows that I go through. I try to read for people who had the same big questions that I'm having now. So I may have some big answers they may have had. I find solace and console in talking to people who share the same why that I have and who are going through the same how. This is Dr. Lubna Bassam, the geriatric psychiatrist that shares leading the cognitive disorders program in KFSH. And of course, my brothers in the Saudi Cognitive and Behavioral Neurology chapter. They are not only colleagues, they are my brothers. Just 2 weeks ago, I texted Dr. Haytham saying, I'm sick of telling people they have Alzheimer's disease and I have nothing to offer them. And he gave me a quite good psychotherapy session. And of course, my best friend, my lifetime partner, the house that he has to put up with is my existential questions that I keep bugging him with every day. Thank you so much. I invite you next week to our annual meeting. I hope we can see you there. Thank you.
Thank you, Dr. Roy. We have time for a few questions in our panel discussion, and then we'll have our award ceremony, and then we will go to lunch. So, do we want to have people come up or just take it in the audience? Why don't we just do the microphones? I have to say, Dr. Roy,
So
yes, go ahead. I'm still a practicing neurologist. I tell people every day that they have a terminal brain disease, and it still upsets me. So I feel what you just said. Yes.
I am Dr. Aboulas Kalboush. A consultant psychiatrist, a member of the College of Psychiatrists. I'm working in Al Ain Hospital. Thanks for all moderators of the conferences, all speakers, and especially Aya for highlighting importance of directing our efforts to families of patients with dementia, and also for neuroplasticity and its importance. And I'd like to add one important thing, which is there is one problem goes unnoticed either by families or by us as the healthcare professionals, which is marginalization of patients with dementia. Sometimes this marginalization is not only because of difficulties the patients experience while doing daily life activities. Sometimes it comes from our instructions to the family to maintain safety of patients, to keep patients away from cookers, for example, important appliances, electrical appliances at home like microwave, because dealing with these electrical devices by patients with dementia who cannot deal well, especially in stages of moderate or severe dementia. All these can lead to danger not only for patients, for the old people in the house. So sometimes keeping patients away from practicing daily life activities, this leads them to progress toward the next stage of dementia rapid than what expected. So my opinion and my recommendation for occupational therapists mainly, not only to make a checklist of difficulties that patients are suffering from and to direct their efforts to help patients to overcome their difficulties, they have, not only they have to make a list of things that patients are not struggling with yet, because with the passage of time, all items should be included in this normal list will be transferred.
Just to make it very short, because we are running out of time. So I will ask Dr. Ru'a if she agreed with this.
Yeah.
Dr. Ru'a.
Okay.
Thank you so much for your comment. Yes, I do agree, and that's actually part of our initial assessment when we do meet with the patients and the caregivers, is a list of things to expect, things to avoid. We do want them to still complete to participate in ADLs, but at this point, we also want them to be supervised and monitors. Because as you know, your daily participation is what keeps you going. So I don't want them to stop cooking or baking or doing the things that they enjoy. It's just, with a little bit of supervision at that time too. We don't want to take away from their, who they are and the things that they want to enjoy.
Yes.
Yeah.
Thank you for this. And
I can take another question? Yes.
Is there another question? Yeah, there's one.
Yes, thank you very much for this conference. This is my first time attending this conference, and I'm really, I learned a lot. I learned a lot during the 3 days that I came, new knowledge, new information. The studies was amazing, and I hope next year there will be more advancement and more new knowledges.
Sure.
So I have 2 questions. One related to support group that was mentioned. And I have to, I will confess that I'm a family member of a patient with dementia in an advanced stage, and I'm a medical background, but my family members are not from the medical background. So the minute I travel out of the country or I leave, they will get a lot of stress, a lot of problems that they cannot handle, and I get a lot of calls. So if there is a program that train, I'm talking from UAE perspective, if there is a program or anything that helps family of or a caregiver of a patient with a dementia or Alzheimer or all those disorders, that from your experience, how difficult it is or how easy it is to develop like a support group like in Saudi Arabia, or just a training classes from one of those facilities that actually provide. The second question related to micronutrient. or any, we're talking about early dementia or early detection of dementia. So patients who've been early detected, if there's anything other than those medications like vitamins like B1 or let us say L-thiamine or any type of micronutrient, is it effective from your experience?
Okay, so answering the first question about the caregiver support group, so it's a special caregiver support group for those falling in the cognitive disorders program that we have. But I can refer you to the Alzheimer Association website. So Saudi Arabia's Alzheimer Society. They provide online caregiver training in Arabic. And their website is full of information for caregivers. It's directed towards caregivers in the first place. So I would recommend that you refer your other family members to that website. Caregiving for dementia patients, terminally ill people, is not easy. It's a huge burden, and it has to be shared by multiple caregivers. No one can do it on their own. So I would recommend going back to that society website. الجمعية السعودية للزهايمر في السعودية. The macronutrient, I'm not sure if anyone else of the experts would like to answer, but there are very small studies that are looking into, or that looked into omega-3 and lion's mane, the mushroom, and I'm not sure if it was magnesium or zinc. So there was a study, a clinical trial that even looked into biomarkers, and it showed that these did reduce the biomarkers. So I always say if it's not harmful, there is no problem in doing it. So these are things that I recommend, especially the omega-3, because there is more evidence on it. But I'm not sure if anyone else would add anything else.
I just want to say thank you.
Yes.
Yes.
Yeah.
The data is mixed. Yes. So,
Last question. If there's anyone is burning question there. Yeah, last one. Yeah, go ahead.
Hello.
Vaccination. I will give it to Marwa. Yes, go ahead.
Hello. Thank you for your time. First, I want to thank Dr. Hanan and team for the excellent one. I really enjoyed. I'm from RAC Medical University, Dr. Shivan. From treatment to, from diagnosis to treatment, I have some suggestion with my little brain. One is treatment related to like herb-based and stem cell-based therapy. Maybe next meeting you can include, because I'm working on stem cells. And that is actually, I have done a work on treatment for dengue infections before COVID, in fact. Fine, just an addition for next time. For the diagnosis, I would like to say one thing which was not discussed related to biophysics. Amyloid is actually behaves like liquid crystals. They are nanocrystals. If they deposit, they are very small. We cannot diagnose them unless otherwise we design something to diagnose. So regular H&E sections, they will not be seen. Like for cholesterol crystals, how we see from the plaques, from the atherosclerotic plaques, because they are big, we can see them. But since they shrink during the preparation, I'm a histopathologist, so we cannot. So what are all these plaques? Are they associated with crystals? And then one more important thing I would like to introduce, that cell membrane, every cell membrane and myelin sheath are actually liquid crystals. So what is the relationship? Is that crystals outside inside the body behave same? Piezoelectricity. We are actually concerned with neurological structures that are related to electricity. So how it is correlated? I want next time to add up. Maybe we can collaborate, and it's really interesting.
Very
Thank
interesting
you so
question.
much.
Thank you. Dr. Marwan, it seems that the upcoming Congress should speak more about the vaccination, someone said there. The other one is regarding these micro and nano levels. So any ideas about these?
First of all, I do think we should have it for the 10th Congress. I will say stem cells has been looked at twice. In fact, there's a company developing stem cells called Longeveron that is moving forward. The question is what is the approach, since stem cells don't get into the CNS? Is it an anti-inflammatory approach? So these are discussions for future conversations. I want to bring the 9th International Conference on Alzheimer's Disease to a close. Thank you all. I do want to introduce
Drs. Hanan Sheikh Ibrahim and Dr. Suhail Al-Rukin as the chair people for the 10th International Conference on Alzheimer's Disease. Okay. And we will have an awards for the speakers. Do you want to do that down there? Okay. Take some pictures. Awards.
So I would like to call Ms. Naya to come to the stage. And Dr. Leopold, please come to the stage.
Wanted to say a big thank you to our lead, FCO, and Olympia University for hosting this, supporting this. We could not have done it without Olympia University or FCO. So I want to say thank you.
الله يخليك هذا ويك يعني شيء صعب أو شيء بالرياض بس ما حدا كلها